We are live now, sir.
Good evening, delegates and faculties member. Thank you for joining Shield Connect. This is the webinar organized by Bihar Obstetric and Gynecological Association. The topic is alert signals in obstetric and gynecological practice. And the key organizer is Dr. Varsha Baste ma'am, who made this webinar possible by gathering all the all the faculties member. And so let me introduce the convener and webinar in charge. Dr. Pratibha Singh ma'am and Dr. Kavita Barnal ma'am. So Dr. Kavita Barnal ma'am is senior consultant and laparoscopic surgeon in Samarpan Hospital in Munger.
We can move forward, Nishant. Just leave it.
Yes, ma'am. And Dr. Pratibha Singh is consultant laparoscopic gynecologist and IVF specialist and director of Healing Touch Hospital of Bhagalpur and chairperson of Foxy IAC Committee 2023-25. So I hand over the session to Dr. Pratibha Singh, ma'am. And first we will start with the light lamping program. Okay. Thank you.
Ankurutvam kalyanam arogyam dhanasampada Shubham kurutvam kalyanam arogyam dhanasampada Shatru buddhi vinashaya Deepajyotir namostute Deepajyotir namostute Shubham kurutvam kalyanam arogyam dhanasampada Shubham kurutvam kalyanam arogyam.
So, good evening, everyone. And I would like to welcome all of you for this alert signal in Obs-Gynae practice webinar today. And I'm really happy today to be the convener of this focus webinar, which is very important for Obs-Gynae conditions, especially its preventive part. But before we start, let me first welcome our guest. And as a convener, I would like to pay my regards to our chief guest, Dr. H.D. Pai sir, President Foxy, who is so busy, but still he makes it a point to be present in all our programs. So hats off to you, sir. And thank you for coming and gracing this occasion. And I also want to acknowledge the presence of our stalwarts from Bihar, respected Dr. Manjugita Mishra Madam, Dr. Anita Madam, Dr. Alka Pandey Madam, Dr. Abharani Madam, Dr. Kubudni Jha Madam, and all who have joined from Bihar and Jharkhand. And now this webinar has been conceptualized by none other than Dr. Varsha Baste, my predecessor, past chair IAC committee, Foxy. And it is her vision of doing such focused webinar across India. So I welcome you, madam, and we all know her. No need to introduce her, but she is a very lively personality, and I wish her all the best of luck for her future endeavors. So over to you, Dr. Varsha, madam, for welcoming.
Thank you, dearest Pratibha, for the warm introduction. I welcome, good evening, all the dignitaries on the dais and the delegates and all the stalwarts from Bihar. I want to acknowledge and say gratitude and welcome Rishikesh Pai sir. In spite of his so busy schedule, he acknowledged and graced the occasion to be the chief guest. But at the same time, I have to acknowledge all the guests of honor people. Dr. Manju Gita Mishra, who is the dear friend. She is my travel buddy since Asia and all. We have traveled a lot. Each one of you is my cast friend, Dr. Anita Singh, Madam, past President, Vice President Foxy. I have never seen such a composed and talented person like her. She has a sea of knowledge, and still she is so shant and ekdam composed person. Alka Pandeyji, demure, soft-spoken, and very nice VP Foxy. The chairpersons, I must acknowledge the names by taking the names of Suman Sinha, a very nice, great friend of ours from Ranchi. Rekha Jha, what should I tell about Rekha Jha? She has the legacy. I call her a British girl because the father is also FRCS and whatnot, and she is like that. she has that aura of British aura. So I really feel, Rekhaja, you are a woman of a substance and different person. Then Professor Vijaya Kumari, Kumutini Jha, Archana Jha, Supriya Jaiswal, our chairperson of FOXI. And at the same time, when I say Suman Sinha, I remember Preeti Rai, Priyanka Garg, Kiran Pandey, all from Ranchi also. Then Beena Jha, Arpita Gandhi, and Roma Yadav. Roma Yadav आपने इतना खिलाया पिलाया है, I cannot forget the delicious खुद के हाथों से मुझे खिलाया, fish and all whatnot. I feel I belong to Bhagalpur, I belong to Jharkhand, I belong to so many times I have been to all places and attended conferences and whatnot. Then we have to acknowledge the presence of our speakers also. The speakers said, yes, we will be there for your webinar. So none other than Dr. Kavita Bapat, who is the FOXI Vice President, and she was also the Organizing Secretary of ASUG Indore, and Dr. Abharani Sinha. What should I say? No, she's such a darling, soft-hearted, always smiling, and calm and quiet and composed person. I'm really, her aura is really gracious. And this, the panel moderators, Pratibha Singh, what should I say about Pratibha? She's my darling. She has done so much of work. मैंने बोला Pratibha ये करना है, वो करना है. Always ready with everything. She was really great national coordinator for my chairperson, International Academic Exchange Committee. देखा जा told and Kavita Barnawal, अरे तुमको देख के तो मुझे मुंगेरी याद आता है, मुंगेरी लाल के आसीन सबने, but Mungeri is really so much wealthy for spiritual knowledge. The guru from the yoga guru, I had been there for centenaries function, and Kavita, you are really blessed to have his blessing and his support and guidance also to you. So I welcome you, the organizing secretary of this webinar also, and from Bhagalpur Society also. The panel moderators I told you, but I have to acknowledge the names of all the panelists also. Nivedita Datta, Lata Gupta, Sangeeta Thakur, Shipra Singh, Arti Dia, Ranjana Sinha, Archana Kumari, and Roma Yadav again. So all these have acknowledged, and they are all present for this lovely webinar, which is very important. Alert signals in OBGYN society practice. I will be handling the hemorrhage part of it. Kavita Bapat will talk about the stillbirth and all, and Abharani Sinha will talk about the another topic in this alert signals in OBGYN practice. So I welcome you all, and I want Dr. Rishikesh Pai to talk a little bit, give us the wisdom of words of your advice. You are such a wonderful person, so friendly, so encouraging, never say no to anything, always encouraging our Mumbai ka boy, and he is holding such a prestigious post of FOXI president. I am really overwhelmed by his tenure. So many years, 20 years or so long, he has devoted to FOXI, and really a role model for us to look forward to. So over to you, Dr. Rishikesh Pai, and Dr. Rekhaja, please introduce him with his CV. Thank you.
रेखा मैडम एक ही लाइन बस हो गया.
एक लाइन में समेट करना है. Okay, good evening, but I have to take the names of all the seniors. So good evening, all the senior dignitaries present here. Dr. Rishikesh Pai, President FOGSI, Dr. Manju Geeta Mishra, the teacher of so many of us in Bihar, Dr. Kavita Bapat, Dr. Alka Pandey, Dr. Anita Singh, Dr. Abharani Sinha, and Dr. Kumudni Jha. All these are my seniors, and none other than Varsha Baste, who is my batchmate. She's my batchmate. So all of you, welcome to this webinar. And Dr. Rishikesh Pai, who is the President FOGSI just now, and the Director of Bloom IVF. He is the Chief Administrator of Manyata, has got 59 awards and over 700 lectures to his name, and it is going on multiplying. I think every day the CV should be changed. That is not being done. It should be changed, and we should make a short. I will make a better CV for you, sir, because you have so many things, and I would like to add a few more good words to it. So if you allow me, I will send it to you. So welcome, sir, and please bless this webinar with your words.
Thank you, madam. I never knew who Dr. Rekha Jha was. Now I know her as if she is my family member. Because, after that yatra, na, we all came very close to each other. So that becomes, really was a game changer for me in my life. When most of the time we do campaign before becoming president. But I did this after becoming president. I came to know, even Aligarh when I went, na, first time I met Dr. Hakim, means I probably met her in, but it never have registered with me. And when I gave her the award, Foxy Award, she said, Dr. Pai, you have given me the award first time. Foxy has given me something. So, lot of recognition, because I think the organization has become very vast. Probably as big as BJP party it is. I always say Foxy is like BJP only. So I was, there are senior people, and I must mention them, that Dr. Manjukita Mishra, she is sitting with her cap mask. I say, Manjukita Mishra, हमको एनालाइज करना पड़ेगा इनका इनका राज क्या है, ये जवानी का राज क्या है, वो देखना पड़ेगा हमको, और आपका एक स्पेशल लेक्चर रखना पड़ेगा कि भाई कैसा जवान रहने का एंड काम करने का. देन ऑफ कोर्स डॉक्टर अनीता सिंह हमारी भी बहुत ही, the other day Anita Singh was there and she said, Dr. Pai, you have not taken my name. And मैंने बराबर लिखा था, और मैं when I'm talking ना, मैं very confused हूँ, तो मैं भूल गया उसका नाम. So I'm really sorry that I forgot to take her name. She's one of our senior most vice presidents and very good lady, very intelligent and very good person. And then of course our two dynamic conveners, हमारी Pratibha Singh and Dr. Varsha Baste, who are there. And then of course Dr. Rekha Jha, who is equally now good. I think and sometimes she'll have to come into the center now, as a chairman at some point. आराम से देखो, मैं सबको बोलता 9 actually when I was vice president, I was a real rebel, because you will not know this, but when I was young, the chairmen were nominated by
Internet.
Your voice is cracking.
Voice is cracking.
Voice थोड़ा सा. You're not audible, Dr. Pai. Network problem हो गया.
Network problem.
So hold on.
It's okay. Now it's good. Yeah.
Hello.
Yes,
Now
yes.
Okay, तो मैं क्या बोल रहा था कि जब when I got in the Chennai conference, I challenged it. I said कि election should be there for chairman, and that's how they started having elections. After that, after many years, again I challenged them, because it was 5 years tenure. I said कि 5 बरस में बेचारे सब मर जाएंगे सब लोग, तो हमने reduce करके 3 बरस का tenure किया. Of course उसमें मेरा एक गलती हो गया कि मैंने बहुत ज्यादा चेयरमैन क्रिएट किया और वाइस प्रेसिडेंट इलेक्शन ज्यादा जोश में होने लगे, बिकॉज सडनली पहले क्या था, चेयरमैन 5 बरस था तो सब शांत थे, अभी सडनली चेयरमैनशिप खत्म है, तो मैंने उधर शायद गलती कर दी थोड़ी. तो बट आई ऑलवेज वांटेड टू, बिकॉज आई कम फ्रॉम द, मैं गली का आदमी हूँ ना, मेरा पिताजी तो एक पीएसएम का प्रोफेसर था, वो गायनेक नहीं था, मेरे को कुछ भी बैकिंग नहीं था, तो आई हैड टू फाइट एट एवरी मोमेंट ऑफ माय लाइफ. अभी भी मैं फाइट कर रहा हूँ. फॉर एग्जाम्पल फिगो में भी मेरे को बाहर रखा गया सबने, इतना मैं सीनियर होके मेरे को बाहर रखा है. 84 से मैं काम करता हूँ फॉक्सी के लिए, मेरे को बाहर रखा है इन्होंने. तो अभी मैं, भगवान ने बोला नहीं तेरे को बाहर रखा ना, अभी हम आपको वापस अंदर लाएंगे. तो मैंने, मेरी जो अगली परीक्षा है मेरी, तो आप, और इसमें मेरे को आपको साथ देना है, क्योंकि आई रिप्रेजेंट यू, आई एम योर सिंबल. मैं जीरो था, जीरो से मैंने स्ट्रगल करके मैं ये जगह में पहुंच गया हूं. तो मेरे इंटरनली आई एम वेरी हैप्पी, बिकॉज आई हैड नो वन, नो बैकिंग. हाँ, मेरे पेरेंट्स गेव मी ब्लेसिंग. पिताजी के पास तो 2000 रुपये तनख्वाह थी उनकी, केएम के प्रोफेसर थे. मैंने कभी छुट्टी भी नहीं ली, हमको कभी छुट्टी पे भी नहीं, पैसा ही नहीं था, घर में ही बैठते थे हम लोग. पर वट एवर इट इज, फ्रॉम दैट पॉइंट ऑफ बैकग्राउंड आई हैव कम अप, एंड लाइक आई नो दैट मेनी ऑफ यू आर लाइक मी ओनली, यू आर माई क्लोन्स, एंड दिस इज आवर टाइम, हमारा टाइम है. आप समझ, अननोन लोगों का टाइम है ये. ये टाइम बहुत इंपॉर्टेंट है हमारे देश के लिए भी. तो anyway, coming to then Kavita Bapat is there again, a very dynamic lady. Then there are so many other people that are there with them. Rekha Jha, Suman Sinha, he's also a dynamic person. I missed her in my yatra, but at some time Supriya Jaiswal हमारी chairman, बहुत अच्छी chairman है. Abharani Sinha, another lovely person. Lata Gupta, Archana Kumari, रोमा यादव, विद्या कुमारी एंड बहुत से. मैं माफ करना मेरे को, सब आप मेरे दिल में हो एकदम. आई लव ऑल ऑफ यू. सो बेसिकली आई एम सेइंग दैट मैंने वो चालू किया ना, मेरा इंस्टॉलेशन हुआ अक्टूबर में. 3 ऑलरेडी युवा हो गए. रणथंभौर में लीला व्यास ने किया, बनारस में अपने अनुराधा जी ने, और आई फॉरगेट द अदर खन्ना आल्सो, दे डिड इट. एंड देन कैलिकट में मल्ल्या और इन्होंने संपत कुमारी ने किया. देन आईसीओजी का कॉन्फ्रेंस हो गया, अपने लक्ष्मी श्रीखंडी ने किया नागपुर में. और संपत कुमारी ने अंडमान में इतना, मैं तो रो पड़ा सावरकर के वो जेल में गया ना, रो पड़ा मैं. कितना मैंने, मेरे को तो भगवान ने, मैं जाने वाला नहीं था, कहाँ से पुश कर दिया ना अंडमान में. कितना मेरा एकदम माइंड में एकदम ऐसा, मैं बोला मैं कितना मैं लकी हूँ कि ये लोगों ने इतना सैक्रिफाइस किया. मेरे पिताजी भी जेल में थे 4 बरस के लिए, 1942 to 46. ही वाज आल्सो फ्रीडम फाइटर. ही वाज इन जेल इन करजत. एंड तो बहुत ही मेरे को इमोशनल हो गया. तो मेरे को भगवान ने रियली लकी होके मेरे को देन ये यात्रा की मैंने आपके साथ. वो एक 21 सिटीज में, तो अभी भी मैं बोलता हूँ ओजस्विनी को, अरे क्या मजा है ना यात्रा में. It was one of the best things in my life. I'll never forget it. It is the peak of my life. What I did was, not for anything else, for my own happiness. I tell you, it was a fantastic thing. And अभी आगे चल के बहुत कुछ प्रोग्राम है. हमारा पटना में अभी बड़ा युवा है, वाइस प्रेसिडेंट कॉन्फ्रेंस है. उधर हमको मिस्टर एंड मिसेस फॉक्सी, ऑल ऑफ यू आर मिसेस फॉक्सी, ऑल ऑफ यू आर स्मार्ट, ब्यूटीफुल, लवली, इंटेलिजेंट. मैं बोला मैं तो जज नहीं होगा, मैं तो कंफ्यूजन में जाऊंगा किसको अवार्ड देने का. एंड देन द यूके में प्रतिभा सिंह का कॉन्फ्रेंस है. प्रतिभा एंड वर्षा एंड ऑल ऑफ अस, हमारा सबका मिलके कॉन्फ्रेंस है. तो और मेरे को लोग मांगता है, मजा आएगा बहुत. देन पेरिस में कॉन्फ्रेंस है. एंड देन नवंबर में हमारा लास्ट मेरे लाइफ का शायद वो ऑफकोर्स एआईसीओजी है, पर मेरे लाइफ का इट फ्रॉम 2000. आई वॉज टेलिंग रिश्मा कि 2000 से लेके अभी तक मैं फॉक्सी के कुछ ना कुछ पद में हूँ. अभी नेक्स्ट ईयर से मैं फ्रॉम हीरो टू जीरो होने वाला हूँ. बट वो डजेंट मैटर, मैं आपके दिल में हूँगा, आप मेरे दिल में रहेगी. आपको कभी भी कुछ लगेगा तो आई एम ऑलवेज देयर फॉर ऑल ऑफ यू टू अंडरस्टैंड. सो आई एम वेरी हैप्पी एंड विश यू द वेरी बेस्ट फॉर दिस लवली प्रोग्राम. यू आर ऑल लवली पीपल एंड you have a good time. Thank you.
Thank you, sir. Thank you, sir. You always speak through your heart. It is really, and we will always love you, sir. And you will always remain in our heart. And yeah, really, sir.
Thank you, everybody.
Thank you.
Let me welcome Dr. Abharani Sinha and Dr. I want to declare Dr. Archana Kumari to congratulate her. She has become professor. So welcome all, Nivedita. रोमा यादव भी आ गई है, सब लोग हमारे आ गए, सुप्रिया भी आ गई है.
कविता, डॉक्टर कविता, प्लीज इंट्रोड्यूस अवर गेस्ट ऑफ ऑनर.
Yeah, thank you, Pratibha Di. So I am really privileged to introduce our own teacher, Dr. Manjugita Misra Madam. So is so lovely, so knowledgeable, and always makes us feel as a mother or guardian. She has served all the platforms. She was professor in PMCH, where we had done BBS as well as MS. And yeah, she has got recipient of many awards, including Dr. Bishira Award, because we are already going late and many persons have messaged that we should start the scientific session. So just I request with great honor, Madam, to bless us and our society.
Thank you, Dr. Kavita. Respected President Foxy, Dr. Rishikesh Pai, the special guest, Dr. Alka Pandey, Vice President Foxy, Dr. Anita Singh, past Vice President Foxy, and the Chairperson IAEC committee, past Dr. Varsha Baste, who is the main organizer of this webinar, and all other speakers, Dr. Kavita Bapat, Dr. Abharani Sinha, Dr. Pratibha Singh, and all other speakers who are present in this hall, especially the President Bhagalpur Society, Dr. Rekha Jha, and Secretary Dr. Kavita Baranwal, because during their tenure, the Bhagalpur Society has done very many webinars, and I think from every person from the FOGSI has visited Bhagalpur, and all have appreciated the conference which was organized by Bhagalpur Society. So, so they have organized this conference in a very big manner, and we all appreciated and we enjoyed the stay at Bhagalpur. So congratulations, Dr. Rekha Jha and Dr. Kavita Baranwal. Actually, Kavita Baranwal was a very dear student of mine, and she has worked with me for many years. So now she is doing very good in her practice also, and in the this activities of FOGSI, especially Bhagalpur OB-GYN Society. The topic which has been selected by Dr. Varsha Baste, first is maternal safety bundles for hemorrhage. I think this is a very important topic, and Varsha Baste will highlight on this topic. And this reminds me of these days the increasing incidence of PAS. That because maternal safety is more important. When we see that these days the incidence of PAS has increased because due to increasing number of cesarean section. And when we are doing cesarean section, suddenly we come across the placenta accreta, percreta, and then we become nervous what to do and what not to do. So in this case also, maternal safety is first, and then that should be always in our mind. The second topic, which is also very important, that is unexplained stillbirth. Many times, patients, they come regularly to us, and suddenly one day the patients visit us, and when we see the patient, the fetal heart sound is absent. Again, that is the very special situation. So we can't understand how to convince the women, how to convince that now the fetal heart sound is absent and the stillbirth has occurred. So the many times we come across the unexplained stillbirth. So that will be, I think all these subjects will be dealt very elaborate manner, and all the members will be benefited by this. Then the panel discussion is on cancer cervix prevention. So I must congratulate Dr. Varsha Baste for organizing this webinar, and my best wishes for the future endeavor. So thank you very much. And once again, I thank all of you for giving me this honor. Thank you very much.
Hello.
So for your blessings and for your kind words, which will always encourage us and will make us to do better. So another guest of honor is our one of the most senior members from Patna, Dr. Anita Singh Madam. She has been a professor past Patna Medical College, and she has served Patna Gynaecological Society as president, vice president FOGSI in 2020, and she has been chairperson endocrinology committee FOGSI between 2014 to 16, member governing council ICOG 2015-20. At present, she is consultant at JP Hospital, Patna, and she is also very humble, sophisticated, and she an ocean of knowledge. So she has hold many posts and has got many awards. I request her to say a few words and to bless our society.
Welcome, Dr. Anita Singh Madam. Welcome. Welcome.
Hello,
Thank you for
hello,
gracing the
Varsha.
occasion.
Anita Madam.
Nice meeting you. Good afternoon, everyone. And thank you, Kavita, for such nice words for me. And so far as this webinar is concerned, I want to congratulate Dr. Rekha, Dr. Kavita, Dr. Varsha Vasudev for having organized it, and thank them also for inviting me as a guest in this webinar, important webinar. And the topics has already been elaborated by my senior Dr. Manjugita Mishra Madam, how important all these topics are for our day-to-day clinical practice. And I hope they have chosen very good speakers also. And I wish a grand success to this webinar, and the wish for the delegates that they return back with lot of more and more information and knowledge about these subjects which are going to be discussed today, and they'll be able to clear their queries regarding it, and we'll be in a better position after the end of this program to manage patients complicated with all these problems. Thank you very much for calling me as a guest.
Thank you, madam. Thank you.
Thank you, madam, for your wonderful blessings. And I think Alka madam has not joined, na? Dr. Alka madam?
No, still she has not.
So she has not joined. So when she'll come, we'll introduce her and take her blessings. And with this, now I hand over the session to Dr. Kavita for the first session.
Yeah, thank you, Dee. So now we are going for the scientific session, and first session is be dealt by no other than our chairperson, Foxy IAC Committee 2019-22, Dr. Varsha Vasudev Madam. Very humble, very lovely, charming personality. And for that, chairpersons are Dr. Sumansana Madam, who has been senior consultant at AHIVF Infertility Center, Ranchi. She is serving Ranchi of Gynaecological Society as president. Very active member. She has got many appreciation awards, and we all know her that we have seen in your Foxy. And another chairperson is Dr. Rekha Madam, that has been already introduced by Varsha Vasudev Madam. Very active, and under her leadership, our society is creating new records. So, and third chairperson is Dr. Vijay Kumari Madam. She is my senior. She was my senior at PMCS. Presently, she is professor in the Department of Gynae at Gaya, and she is member of many societies. So with these words, I request Vijay Kumari Di to introduce Varsha Madam. Is she there?
No.
Rekha Madam, you introduce.
Oh, so I have to introduce lovely Dr. Varsha Vasudev. She is a practicing gynecologist and infertility specialist in Nasik since 30 years, director of Vasudev Maternity Hospital and Pushpa Fertility Center, first ICSI PGD baby in North Maharashtra, past president at Nasik, chairperson Foxy IAEC in 1922, and she has got the prestigious Dr. Anandi Bai Joshi Award. AMOG's V for Stree Puraskar by Honorable Governor of Maharashtra, Foxy Chairpersons of Foxy Award, and Foxy Excellence Award for Outgoing Foxy Chairperson. Organized many national and international conferences, participated in numerous national and international conferences, and the founder, member of MSR Maharashtra ISAR, life member of IAEG, fellow ICOG, FICOG, and diploma in infertility, Kiel University, Germany. Was so welcome, Dr. Varsha, and I would like to invite you for your deliberation. You can start.
Thank you so much, Dr. Rekha. I will share my presentation. Just a minute. Can you see the screen?
Yeah, it is
visible.
Okay, so I'm starting my presentation as maternal safety bundle for obstetric hemorrhage, because this is very, very important topic, and for our day-to-day life. PPH management, but the core is prevention and to know beforehand and then act. So this maternal safety bundle of obstetric hemorrhage has really worked very well, and let us see what it is. The objective was describe the magnitude of problem, take a look at processes, methods, and tools that were used to develop the obstetric hemorrhage patient safety bundle, provide an overview of bundle components, give suggestions for how to effectively implement and utilize bundle within your organization, and identify resources to customize for use within your organization. Some hospitals are big, some are small, some are private. We have to see the infrastructure, the facilities available, and we have to update them, and also the staff training. So What is obstetric hemorrhage? Traditionally, the definition is more than 500 ml after vaginal birth or more than 1000 ml after cesarean section. The ACOG revitalized definition like 1000 ml cumulative blood loss or blood loss accompanied by signs and symptoms of hypovolemia within first 24 hours after delivery, regardless of the route of delivery. The incidence is about 4 to 5% of the birth. So maternal mortality and severe morbidity, there are many conditions like amniotic fluid embolism, infection, preeclampsia, cardiac diseases, but above all, the hemorrhage causes mortality more than 15%, ICU admissions are more than 30%, and severe morbidity after delivery and after this trauma and everything is almost 45%. So what are the causes? Because the pregnant women are dying from what? We have to save the mother life, but we should know the causes. So the 28% die of pre-existing medical condition exacerbated by pregnancy, such as diabetes, malaria, HIV, obesity. 3% by blood clot problem, abortion complication. 8% obstetric labor and other direct causes are 9%. 27% having severe bleeding. 14% pregnancy-induced high blood pressure, and infections almost 11%, mostly after childbirth. So the etiologies of obstetric hemorrhage, uterine atony, almost 80% of the total, genital tract lacerations, abnormal placentation, previa, morbidly adherent placenta, abruption, retained placenta, uterine inversion, maternal coagulopathy, hereditary and acquired. So what are the complications because of this obstetric hemorrhage? Severe anemia, hypolonic shock, consumptive coagulopathy, acute or renal, acute or chronic renal or liver failure, acute pulmonary edema, transfusion reaction, Sheehan syndrome, that is because of severe anemia, less blood supply, so postpartum pituitary necrosis, myocardial ischemia, and death. Failure to recognize excessive blood loss during childbirth is the leading cause of maternal morbidity and mortality. Women die from obstetric hemorrhage because of lack of effective and early interventions. So addressing the problem and development of patient safety bundles is very, very important. So ACOD, CDC maternal morbidity, severe morbidity action meeting occurred in Atlanta in November 2012. The participants identified key priorities like core patient safety bundles, obstetric hemorrhage, severe hypertension in pregnancy, venous thromboembolism prevention in pregnancy, supplement patient safety bundles where maternal early warning criteria, facility review, family and staff support, and 6 multidisciplinary working groups were formed. The Council on Patient Safety was formed in July 13. Endorsed the concept of 3 maternal safety bundles. The bundle represents outlines of recommended protocols and materials important to safe care, but the specific contents and protocols should be individualized to meet local capabilities. Hemorrhage safety bundle details were endorsed by the Council in July 2014. So what were the goal of obstetric hemorrhage, the safety of these patient safety bundle? To improve readiness to hemorrhage by identifying the standardized protocol, general or massive. Improve recognition of obstetric hemorrhage by performing ongoing objective quantification of actual blood loss. Improve response to hemorrhage by utilizing unit standard, stage-based obstetric hemorrhage emergency management plans with checklists. Improve reporting system, learning of obstetric hemorrhage by performing regular on-site multi-professional hemorrhage drills. So there are 4 domains of patient safety bundles. One is readiness, recognition and prevention, response, reporting system, and learning. So the readiness of every unit of the hospital. The hemorrhage card we all know. Immediately available antepartum, postpartum, multidisciplinary input for development, stocking and maintenance, containing supply, checklist, instruction card for intrauterine balloons and compression stitches. So this is the standard hemorrhage card. So what are the recommended instruments for hemorrhage card for if which is going for vaginal delivery, vaginal retractor, long weight speculum, long instruments like needle holder, Caesar, Kelly clamps, sponge forceps, intrauterine balloon, benzocaurate, bright task, light, and procedural instruction like balloon. And then for cesarean or laparotomy, hysterectomy tray should be ready. Number 1, chromic or plain catgut, suture material, reloadable state needle if we have to go for Billings suture or other sutures, intrauterine balloon, procedures instruction like balloon Billings and arterial ligations. Readiness, immediate access to hemorrhage medications. The kit or equivalent should be there. Consideration including safe storage and assess time to bedside in drill. So this medication kit, what does it contain? It should have oxytocin, pitocin, premix bag, IV, pitocin, carboprose, mesoprostol, methergine. These are all the bundles they had endorsed in 2014. Now we have added carbotocin also in the kit. So hemorrhage response team, the drills and evaluation of team are critical. Surgical critical care support is must with gynaecology, maternal fetal medicine person, general ops gynae, critical care, general surgeon, urologist. Anesthesia support, second or third person, nursing support, additional staff, administrative support, blood bank and lab staff. So massive transfusion protocol. In order to provide safe obstetric care, institution must have functioning massive transport protocol, have a functioning emergency release protocol, minimum 4 units of O negative or uncross-matched packed self RBCs, have ability to obtain 6 units of these packed RBCs or 4 units FFP compatible or type specific for a bleeding patient, and have a mechanism in place to obtain platelets and additional products in timely fashion. So unit education on protocol, regular unit-based drills with debriefing is very, very important. Familiarize all team members with entire safety bundle and new management plan, identification of correctable systems issues, practice team-related skills. Then comes the recognition and prevention. Assessment of hemorrhage risk is very, very important as an anticipatory plan. Measurement of cumulative blood loss, active management of third stage of labor, all allow for anticipatory plan. So this is the flow chart. So admission hemorrhage risk assessment tool. When we call it as a low risk, when it is only singleton pregnancy, less than 4 previous deliveries, unscarred uterus, and absence of PPH. The medium risk is prior cesarean or uterine surgery. There are more than 4 deliveries, patient with multiple gestation, large uterine fibroid, chorioamnionitis, morbidly obese like BMI more than 35, estimated fetal weight more than 4 kg, and history of PPH. Iris, type and cross the blood, and previa, if the patient is having previa, acrita, incrita, percrita, hematocrit less than 30, bleeding at admission, known coagulation defect, platelet less than 1 lakh, abnormal vital signs like tachycardia or hypotension. Now, measurement of cumulative blood loss. Formal accurate measurement with calibrated drapes and canisters, or weighing blood soak items, clots. Visual assessment of blood loss is also very, very important. We all know this chart of blood loss assessment in obstetric hemorrhage. So that will tell us about the amount of blood loss the patient has occurred. The active management of third stage of labor. Initiation of oxytocin IV or IM immediately upon delivery of anterior shoulder of the baby, either at the time of vaginal or cesarean birth. Other components include research and clinical protocols have included controlled contraction and vigorous fundal massage. Oxytocin is a key element and other component not proven to impact blood loss. Now the response for early hemorrhage, unit standard, stage-based, obstetric hemorrhage emergency management plan with checklists is very, very important. Support program for patients, families, debriefing, and the staff for all significant hemorrhages is a must. So there are these stages. The stage 1, blood loss more than 500 ml, vaginal blood loss more than, if vaginal delivery more than 1000 ml, if cesarean with normal vital signs or lab values. The initial steps are ensure 16 to 18 gauge IV excess, increase crystalloid without oxytocin, insert indwelling urinary catheter, fundal massage, medication, increase oxytocin or additional uterotonics, blood bank type 2 and type and cross-match 2 units of RBCs, Paxil. Action is to determine etiology and treat, prepare for operation theater if clinically indicated. Then these are the drugs like oxytocin, methergine, and carboprose, misoprostol. And we have to be ready with all these uterotonics. So 4 T's: tone, atony, trauma, laceration, tissue retain products, and thrombin coagulation dysfunctions are very, very important to monitor. Stage 2, continue bleeding up to more than 1500 ml of the blood loss. More than 2 uterotonics with normal vital signs and lab values are to be initiated. So initial stage, mobilize the additional help, place second IV 16 to 18 gauge, draw blood for CBC, coagulation and fibrinogen factors, prepare for operation theater. Medication continue as stage 1 medication. Blood bank, obtain 2 units of RBCs. Do not wait for labs. Transfuse as per clinical signs and symptoms. Thought 2 units of FFP. Action is the escalate therapy with goal of hemostasis. Handle and move to stage 3 if continue blood loss or abnormal these vital signs. So intrauterine balloon technique: insert under ultrasound guide, inflate 500 cc with sterile water or normal saline, use vaginal packing, soak with iodoforms or antibiotic to maintain correct placement and maximum tamponade, gentle traction to secure to the patient's leg. So these are the surgical management of these PPIs, like placental bed suture, uterine artery ligation, uterovarian ligation, repair uterine rupture. You can take B-Lynch or Hammond different sutures, or finally, if not, hysterectomy. So next stage is continued bleeding with effective blood loss more than 1500 ml, or 2 units or RBCs given, or patient at risk for occult bleeding, coagulopathy, or any patient with abnormal vital signs, lab or oliguria. Initial step is mobilize additional help, move to OT, announce clinical status, vital sign, cumulative blood loss, etiology, outline and communicate plan. Medications are like this, and continue stage 1 medication. Blood bank is important. Initiate massive transfusion protocol. If clinical coagulopathy, add cryoprecipitate, consult for additional agents, and action is to achieve hemostasis interventions based on etiology. So checklist is very, very important. Cardiovascular, the last stage 4, cardiovascular collapse, massive hemorrhage, profound hypovolemic shock or amniotic fluid embolism. Initial step, mobilize additional sources, medications, advanced cardiac life support, blood bank, simultaneous aggressive massive transfusion, action, immediate surgical intervention to ensure hemostasis, like you can go for even hysterectomy. So response post-hemorrhage management is determine disposition of the patient, whether ICU is required, debrief with the whole obstetric care team, debriefing of the patient and family is also very important, document. Support program for patient, family, staff for all hemorrhages, as it is a traumatic event for all. So reporting is very important. System learning for every unit. Manyata is doing fantastic work about it, because I see my staff body language has changed. They are more confident, and the PPS drill and all what we do consistently, intermittently, that helps them to keep the knowledge at par. Establish a culture of 100 for high risk patient and post-event debriefing. Debrief, 100s and debrief become the part of routine, will improve clarity, role clarity, situational awareness, and utilization of available sources. Multidisciplinary review of serious hemorrhages for system issues, formal meeting to identify any system issues and breakdowns that influence the outcome of the event. We have to retrospectively see what was the fault we had dealing with the patient, and we have to improve it. Multidisciplinary perinatal quality committee, sanction and protected. So monitor outcomes and process metrics in perinatal quality improvement committee. Process measures used to document frequency that a new approach is used. Outcome measures used to determine project success. Goal is to reduce the number of hemorrhages that result in severe morbidity and mortality. Follow internally 4 or more units of RBC and require ICU care. So friends, with this, FOXI awareness, social awareness, government awareness, and the help and blood bank components and everything is easily available, and multidisciplinary approach. We have many people to expert people to help us. So India's MMR has been falling down very well. In Maharashtra, it is almost 67. In other areas, it is more than 100, but it will come down definitely less. So the conclusion is early opportunity exists to assess risk, anticipate, and plan in advance for an obstetric hemorrhage. Multidisciplinary coordination preparation, particularly with the blood bank, is critical in order to provide safe obstetrical care. A standardized approach to obstetric hemorrhage includes a clearly defined stage checklist of appropriate actions to be taken in an emergency situation. It can help to improve patients' outcomes. Thank you for your patient hearing. Friends, I am going for the post of Vice President Foxy West Zone. I need your blessing and support. Thank you for your patient hearing.
Thank you, madam. Now I request Suman madam to please conclude and give expert comments. Suman madam, are you there?
Yeah, I'm there. Can you see me? Okay, can you hear me now? So, very good evening to all of you. Thank you, Barsa madam, Dr. Rekha Jha, and Dr. Kavita, and the whole organizing team for giving me this very valuable opportunity. So, Dr. Barsa, you are superb. It was really a very extensive and lucid presentation. Every part of management of hemorrhage is there. So, one thing I can just understand is that we should focus on 4 parts. That is very important. Just to be ready. You have to be prepared. Whatever case comes, you are prepared. So if you know everything, and for that, always PPH drills should be done. Even the case is not there, but all the staffs, all the subordinates, all the doctors, they should be planned. And the toolkit for the instruments and the necessary things, it should be ready. So it should be readiness and a response, and then you have to recognize. And the moment you recognize, you have to call for help. That is also very important. Maybe that one person is not that much, confident to tackle the case, but you unite all your group, and that is decided from before who is going to come, whom to call. Sister should know. So that if that planning is done, so I think definitely we are going to save our mothers from dying from PPH. Yes, of course, PPH is the most important cause, but nowadays this PIH has also come. It is equally, we have to be trained not only for the management of PPH, but also for the management of hypertension. That is also very important cause. And nowadays, earlier used to be uterine atony. That was a very important cause, but now it is coming placenta acrita. This
I know.
Yesterday I was doing one cesarean of previous 2 season. I was scared nothing of it, because nothing. I was only asking sister, placenta kahan pe hai? Is it fundal or it is anterior? This is the first thing you want to know prior hand, so that you are not in a panic. So friends, don't go in panic. If you go according to the program as Dr. Barsa has enumerated, I think we can help. We can do much help to the society in bringing down the maternal mortality rate. And Jharkhand is doing very good. Our maternal mortality rate is low, comparable to other parts of.
Wow.
So thank you very much for giving this opportunity.
Vijay is there? Dr. Vijay Kumari madam?
Thank you, Dr. Suman madam. And we have with us Dr. Alka Pandey madam. So she is our guest of honor. So
Good evening, Dr. Alka Pandey ji. Namaste. Welcome.
And she is our Vice President Foxy Zone. And she will be doing a very wonderful conference, Labor Con, in next month. So I welcome Alka madam, and I'll request her to give some pearls of wisdom to us, some blessings to us. Over to Alka madam.
Kavita.
जी मैडम.
प्रतिभा.
Yes.
हाँ मैडम आप सुनाई पड़ रहा है, दिख भी रही है.
सुनाई पड़ रहा है मैडम. हाँ, बोलिए मैडम.
बोल रहे हैं कि आप लोग जो कर रहे हैं पीपीएच पर और हाइपरटेंशन पर, मैंने अलर्ट साइंस पर जो कर रहे हैं, बहुत अच्छा कर रहे हैं. मतलब every one of us need to be alert for any emergency, and help should be sought immediately if you feel that in some soup, because 2 or 3 people, when they are there, you have a great moral support and your nerves are right. So you should always call for help. And of course, everyone knows the management. Everyone knows how to manage. Every day, Kavita is doing a conference, a webinar. Pratibha is doing a webinar, teaching us. So the
main thing is now you have to keep your nerves straight and you have to be ready with everything.
Yes.
Every day, any case can become an emergency. So I wish you all the best, Dr. Varsha.
Thank you. Thank you, madam, so much. Thank you so much for gracing the occasion. Thank you so
Thank
much
you.
and blessing
Thank
us.
you. Thank you so much, madam. Thank you, madam. And now we will move on to our now we will move on to our next session. Now this session is on unexplained stillbirths. So what I want to say that it is said that in worldwide it is approximately 2.6 million babies are born stillbirth, and most of the time it is unexplained, and it becomes such traumatic for both the mother as well as for the treating obstetrician. So today we have a great speaker, our own Dr. Kavita Bapaddi. So she'll be talking on this, and to chair the session, we have a equally qualified and equally knowledgeable chairpersons, Dr. Kumudni Jha madam. We all know about her capabilities. So I welcome Dr. Kumudni madam, and our next chairperson is Dr. Archana Jha, again a very popular in the society, and she is at present Vice President Bhagalpur Obstetrics Society and Secretary in Bhagalpur Menopause Society. So welcome Dr. Archana Jha. And our third chairperson is again a very dear friend of mine, Dr. Supriya Jaiswal. She is chairperson Adolescent Health Committee Foxy 2325, and she had a very successful secretary Patna Obstetrics Society tenure last year. So welcome Dr. Supriya Jaiswal. Now I hand over the session to you all to please introduce our speaker. I request Dr. Supriya to kindly introduce. Can I have the CV of Dr. Kavita Bapaddi?
First of all, a very good evening to all of you. And then I bring greetings from Patna OBGY Society and also from Foxy. Thank you, Dr. Varsha Baste madam, for involving me in this webinar. Also, I thank the President and Secretary, Dr. Rekha Jhadi and Dr. Kavita Barnowal ma'am, also Pratibha Singhdi for involving me in this program. It's a wonderful webinar today. So just to formally introduce Madam Kavita Bapat, she is, first of all, a very charming personality. And then Madam has been a very successful, she has just crossed this tenure of her vice presidentship of Foxy. And Madam is also, she had been the chairperson of breast committee also before, previously. Madam has got so many accolades to her credit. Her personality is very vibrant. And these things I want to say about her, she is full of fun and laughter. Let's grow together with a lot of great ideas, fun and laughter, what she says here. And Madam, with these words, you have got so many accolades that the CV will not finish. So with these words, I really welcome you to.
Thank you so much.
Thank you, Dr. Kavita Bapat madam, for gracing the occasion and even raising the standard of this webinar.
Thank you.
She speaks simply speaking.
Thank you so much, each and everyone over there. Thanks, Varsha and Kavita and Pratibha, for making this webinar. And मेरा तो दिन बन गया वैसे ही अलका मैडम दिख गई मेरी आवा दिख रही है, सुप्रिया दिख रही है, कुंदी झा दिख नहीं रही मुझे, and Rekha and Suman are there, जो मेरे को वीडियो खुले हुए मैं बोल रही हूँ. So allow me to share my screen. And it's very important topic. Probably I'm speaking on this topic for last 3 days repeatedly, and I'm enjoying this topic. The unexpected stillbirth. See, this is the subject which has not been. हम लोग बहुत PPH की बात करते हैं, हम बहुत सारी चीजों की बात करते हैं, but this stillbirth, unexpected stillbirth is a really the worst scenario when we face it. It divides 3 divisions when we talk about. There are very important. एक तो total हम medical legal issue पे we can talk on the stillbirth. Number 1. Number 2, why it happened and how to declare the dead baby to the parents. It's another big subject जिसके ऊपर हम 20 मिनट बोल सकते हैं. One is the medical legal, another is when to declare, and third, what actually happens and how we obstetricians and gynecologists are responsible or not even responsible for this subject, and still the unexpected stillbirth is there. Happy to announce that I come from the place Indore. I'm always proud for that. But it is strange but true that the most important turning points of the life that come at the most unexpected times and the most unexpected ways. I think everybody will believe me. It's not so simple. Kab kya hone wala hai, most of the time we don't know, and it comes most unexpected ways. So same with a stillbirth. A stillbirth is a devastating reality that can happen to any family and can take a serious toll on the families and a community. बच्चा मरना इस देश का सबसे खराब सिनेरियो है, and जो उसको सफर करते हैं, या I'm sure all of there who are listening today will agree with me, किसी को still birth होता है तो सबसे पहले बुरा हमें लगता है. Then we go into the different space of things कि क्या है क्या नहीं है. So it's one of the most devastating life event, substantial physical, psychosociological impacts on women, families and societies. Huge health public concern, and globally in 2019 estimated 1.9 million babies were stillborn, and India topped the wrong charts with the maximum numbers of stillbirths. We don't have any top guidelines on it, no proper guidelines for the how to treat, how to deal, how to find it out. So it's a difficult subject, but the irony that the stillbirth have been absent from the most of the programs so far. We have the PPH program, we have the fetal medicine program. There are so many programs all over the India in a government agencies, in a private, but the program, there is no program for the stillbirths yet. And it's invisible because of the social taboos, stigma, and isolation. Every unborn baby has right to receive the breast care, and all bereaved parents must have the highest quality of the respectful bereavement care. It's not only that the baby died, but the mother, the family, how to treat them is very, very important. And temptation to quit will be the greatest just before you are about to succeed. So it's really a bad thing, and preventing a stillbirth is a lifetime livelihood for the family. So what actually happens? So number one, we have a count every stillbirth. Number two, we have to improve the quality care during the pregnancy and a child care. You should have the increased awareness for the stillbirth, and we should provide the bereavement care. We should not leave the family as it is. I'm just putting a one issue which is being discussed and being in a very big lawsuit in this country. The claimant was 38-year-old, suffered a stillbirth while under the care of Dividend Trust. She claimed that the negligent is failing to recognize the baby was not growing normally, failing to carry out the growth scan in spite of the hospital attendances for reduced fetal movement. She came 110 times for the reduced fetal movement, but the scan says that she is fine, she is fine, she is fine. Has this been performed, it would have been identified there was a reduced liquor, baby was small and delivered expedited earlier, preventing the stillbirth. She claimed the damage on the grounds of suffering psychiatric injury and suffered a loss of self-confidence and was unable to return to work. So you can understand this is a very common thing and which can happen. So now I'll define how we say what is the stillbirth. Number one, we should differentiate between the fetal death and a stillbirth. Fetal death prior to the complete expulsion of the extraction from its mother and the product of human conception, irrespective of the duration of pregnancy. That's very important, which is not induced termination of pregnancy. An unexpected stillbirth occurs 0.5 per 1,000 live births over the 24 weeks of gestation, and most have identifiable obstetric and a perinatal antecedents. So delivery of a fetus showing no signs of life. Number one, there can be absence of breathing, absence of heartbeat, umbilical cord pulsation are absent, but there can be or cannot be a definite voluntary movements, but it excludes the transient cardiac contractions and a fleeting respiratory effort that we can say gasp. So we have to clear it away, and not all the fetal deaths are stillbirth. WHO says the fetal death late in pregnancy allows each country to define gestational age at which fetal death is considered stillbirth. So that's the reason, because it has given to each and every country when they can say that this is the stillbirth. There are no right guidelines, no proper guidelines, nothing is there over there. They can say the 16 to 28 weeks. In WHO says, National Center of the Health Statistics, most states use 20 weeks or the fetal weight is more than 350 grams or more than 500 grams. 28 weeks, it's a late stillbirth, and the Tennessee code annotated that fetal death more than 500 grams in the absence of weight, with that saying than the more than 22 weeks. So completed gestation weeks. So the definitions are also varied, but still we should consider 22 weeks completed and more than 500 grams weight should be there. More than 3 million stillbirths each every year worldwide. 2005 rate 6.2 in the US, and rate of early birth has remained stable, and late fetal pause has decreased by 29%. So it's another point. IUFD and SB, what we deal and we talk about is a different. But why the problem is more diabetes mellitus is there, more hypertension, more abruption, and more PPROM is there and leading to these problems. So these are the points. Unknown etiology in a cases of 25 to 60% of cases, and identifiable causes can be attributed to the maternal conditions, fetal condition, and the placental conditions. So the maternal condition can be prolonged pregnancy, diabetes, which is poorly controlled. SLE is another important point. APAS is another point. Infection, hypertension, preeclampsia, eclampsia, hemoglobinopathies. Even when we were students, we never used to talk much about these subjects. But with the advent of many more tests and everything, we always talk about these tests. AMA, RH disease, uterine rupture. I'm sure the seniors sitting over there or equivalent batches of mine sitting are there. Nowadays, we don't see uterine rupture. But uterine rupture, SB, we have seen a lot when we were students. Maternal trauma or death is another thing. And inherited thrombophilia. The fetal gestation conditions can be the gestation multiple, IUGR, congenital anomalies, genetic anomalies, infection, and hydrops. Now we don't see nowadays much hydrops, but when we were students, we used to see so many hydrops over there. Now placental condition, there can be a cord accident, there can be abruption, there can be PROM, vasa previa, fetal-maternal hemorrhage, and placental insufficiency. And most types of the frequent types of the stillbirth, according to the gestational age, they are like that. For example, they are 24 to 27 weeks, the chances of infection is more. If there is a death of baby or this is stillbirth is 28 to 37 weeks, then most of the time it is unexplained. 37 plus weeks, unexplained. In 24 to 27 weeks, abruptio placentae, they cause 14%, fetal malnutrition 19% in 37 weeks, and 37 plus weeks, again the fetal malnutrition 14%. Anomalies, they should have in the early stage, that is 24 to 27 weeks, 14% SB, abruptio placentae 18% if this is a 28 to 37 weeks pregnancy, and 37 plus weeks pregnancy, abruptio placentae is 12%. So the number one reason they have found out is infection, and the most common cause between 24 to 37 weeks contribute to stillbirth rate is difficult to define. Some pathogens are clearly causing and related to it. This is a provo-B19 virus, cytomegalovirus, toxoplasmosis, and some are associated with the absent evidence of causal relationship by the uriplasma, urolithium, and mycoplasma hominis. So you can understand infection is one of the reasons, and the GBS. We don't test GBS in our country, but then all the GBS is one of the very important cause for many things. And then the colonization common among the healthy women. Now, infection, most stillbirth occur in a premature fetuses, 19% less than 20 weeks and 2% at term. No change despite the widespread use of antibiotics. So you can understand giving antibiotics still cannot change these things. And viral pathogens are most common source of hematogenous infections of the placenta. So it's not the baby, it's the placenta is the culprit. Fetal death resulting from the maternal infection is rare, and diagnostic criteria are yet not well defined. The problem again starts with it, where we are. Then the high frequency of asymptomatic maternal colonization is there. Multiple gestation, all of us seen so many twin pregnancy, triplet pregnancy, and the stillbirths are maximum with multiple 4 times more than the singletons. And complications specific to the multigenes is a TTTS because there is a transmission syndrome, increased risk of complication AMA, fetal anomalies, growth restriction. Now, advanced age. This is the third reason for this advanced maternal age is a lethal and congenital chromosomal anomaly. It cannot say that the stillbirth are there, but if there is an anomaly into the babies, there are chances of having the stillbirth with up to 24 weeks. And the medical complications associated with age, multiple gestation, hypertension, diabetes, and AMA is an independent risk factor, and unexplained fetal demise is the only type that's statistically more common in late pregnancy. Again, in advanced maternal age, risk is behavioral, socioeconomic, and obstetrics, smoking, diabetes, preeclampsia. But risk remains even controlling for above. So whatever the theories are there, whatever we are going to talk about, smoking, diabetes, risk is always there, but we are not able to control. And the perception of the fetal movement is another very important point. Hyperlipidemia is another point. And apnea, hypoxia events is the future things, because of the hyperlipidemia can lead to apnea or hypoxia events unless of this. Then the obesity, as we have seen the academic obesity in our country, we are talking, teaching, mentoring, coaching, what not we are doing every day. So same with the obesity is also a very big problem of this country. And the stillbirth rate depends upon the BMI. It's also been tested, found it out. If it's less than 30, 5.5, 30 to 39, 8, more than 40, there are chances of stillbirth is 11. So more than 40 is a horribly obese patients, and the stillbirth chances are more. Now the chromosomal anomalies are another thing. All the Down syndrome patient like that also, monosomy, trisomy, 18, 21, 13 also, and more than 20% anatomic abnormalities or the growth restrictions can lead to stillbirths. And 4.6 with a normally fetus is formed. Karyotypic analysis, we cannot underestimate the risk, but they are important. Again, with this, we have to find out the method and the success rate, amniocentesis, CVS for this chromosomal diagnosis, and fetal tissue sampling is important. What fetal tissues? Umbilical cord, fascia lata, cartilage, fetal blood, pericardium, and other tissues. They are important when we relate about the stillbirth. Umbilical cord, we can find it out in 32.1%, fascia lata 29.9%, cartilage, fetal tissue and fetal blood, pericardium is 0%, and other tissue 19.2%. Placenta, skin, and unknown. So these are the very important. If we give the postpartum of the baby is done and we can find it out. Cord accidents has got a big role. 30% of normal pregnancy, 2.5% of the stillbirth in an autopsy case series. Attribution requires cord occlusion, hypoxia state on autopsy, exclusion of other causes, and basically it leads to actual proportion remains uncertain. So cord accidents are very important, and we don't do the autopsy in every baby, and if we have done, we could have found the cord occlusion. We can find it out the hypoxic tissue in autopsy. Thrombophilia is another relationship with the late fetal death is more consistent than early losses. It has been associated late loss, but the lack of evidence of the causal relationship. The thrombophilia has got a big role. Then there are inconsistent studies, and it varies from 1.8 to 12, and thrombophilia is not that uncommon. 15 to 25% in a Caucasian problem is there. Thrombophilia, some but all studies show relationship with the adverse outcome, and there is no cross-control studies inappropriate to control. Evaluation is not there. One type of thrombophilia is seen in 30% of the normal controls. So when the baby of the SB is there, what evaluation we should do? It's very important. Number one and most important, fetal biopsy. The moment we have the SB baby, we should write for the postmortem of that baby. That's very important. Most useful test. Examination of the placenta, cord and membranes. Karyotype evaluation is important. 18 to 13% is because of stillbirth, is because of this. There is a comparative genomic hybridization should be done. Usual when the fetal cells cannot be cultured. See, I have given you the list of the fetal cells which should be cultured, but sometimes because of the late or anything, if fetal cells cannot be cultured, so the fetus, this hybridization, genomic hybridization has got the role. Again, in autopsy and histological evaluation of placenta, membrane, and cord should provide the evidence of infectious etiology, value of routine culture, serology, controversial, and there is a screening of syphilis, torch, but so all those things are not so important. And placental culture is a problematic. Incidence of live birth is unknown, and DNA test associated with the false positive. So you can understand how much if you're going to spend money on the stillbirth testing also, and still we are not getting anything. Now these are the medical complications where when we see that there is a SB, clinically if there is a diabetes or thyroid dysfunction, GDM and stillbirth rate similar to normal, subclinical thyroid disease has not been proven to the cause of stillbirth. And the screening of subclinical disease, unproven disease. Now, why we are important to talk about the antepartum surveillance? For whom we are talking about the antepartum surveillance? Antepartum surveillance for those who have the previous unexplained stillbirth. So in the next pregnancy, our role comes. So 30 to 34 weeks, we should worry about. 2 to 4 weeks before the gestation of the previous stillbirth, we have to deliver the baby. But there are the chances of risk of iatrogenic prematurity and subsequent will have a favorable outcome. So stillbirth doesn't end on that pregnancy. Our responsibility as OB/GYN comes in the next pregnancy also. कहीं और stillbirth हुआ होता है और ऐसे वाले patient हमारे पास ज़्यादा आते हैं. Then they say कि मैडम पिछली बार stillbirth हुआ है. So the whole 9 months we are so much worried. I'm sure everyone becomes. So what this study is being done. 300 women with previous stillbirth, 49 unexplained, 1 recurrent stillbirth despite of reassuring testing, perinatal mortality 3.3. And earliest delivery associated with a positive test result was 32 weeks. Then antepartum testing protocol is similar for all. It's non-recurring condition, but we should be worried about the maternal trauma in a previous perinatal infection, fetal anomalies, and we should be worried about the abruption, prolapse, and uterus ruptures are there. So all this is a really big slide, but I'll just make it in a few lines. It's a medical legal issue. It's a very big thing. Advice postmortem, correct counseling, what are the individual and the religious belief they have, we should respect them, they should bury the baby or they should burn they should do the antim sanskar of that baby should be done, we should take all the written consent, we should do whatever the invasive procedure on the baby, we should have all the genetic tissue or the genetic analysis we should do, and consent should be taken and supervised by the obstetrician when we do this type of things. And a perinatal postmortem, including retention of any tissue or a clinical investigation, research, and training. Parents should be offered the description of what happened during the procedure and likely the appearance of the baby afterwards is very, very important. And they should be treated with a dignity. We should do their arrangement report, we should discuss, and we should supplement the offer and we should teach them what actually happened. Again, the conclusion is like that, the stillbirth is the most important indicator quality of care. It's not that whatever the stillbirth we are talking about, it's really the indicator of the quality care. See, in the maternal mortality is maximum in India nowadays in Madhya Pradesh, you're surprised to tell about it and feel sorry about it. But see, it's a bad thing because we need at the end of the day good quality care, and it indicates what is this? It's a sensitive marker of the health system strength. And it's a measure the progress of achieving SDG targets for reduction of neonatal maternal under 5 mortality, but the progress of these targets aimed to reducing the poverty and increasing the equity and access of the healthcare. See, the leadership is an action leading to the group of the people, but basically all these things needed a good guidance, not many directions, control and influence. So we need a good leader to do about all those things, and extra directed efforts is necessary for overcoming the barriers of these things. And again, awareness, health education, we need a demand of creation in a community, socio-economic upliftment of the population. We need a good transport, physical roads and everything, communication infrastructure, and one hand manpower development in the effective deployment of the health sector on the other. So at the end of this, my conclusion is the women's empowerment plays an important role in reducing the stillbirth. You should be empowered, the obstetrician is empowered, our leaders should be empowered over there. The patient, the mother, the child, everyone, the family, everybody, every female should be empowered with this. Thank you so much for giving me the chance, and every member matters is my motto. Thank you so much.
Thank you, madam. Now invite Dr. Kumudni Jha, madam, to give her comments, expert comments. Is Kumudni madam here? Madam? Dr. Archana Di, are you there? I don't know. I think Pratibha Di, are you there? So I think Abha madam is there. So please conclude Kavita Bapat talk. It is already
wonderful.
Well explained.
Thanks for giving me the opportunity to conclude Kavita's talk. So Kavita, as usual, she was wonderful, and she has divided the topic in a very lucid way. She has looked up at the medical legal aspects, about the demographic aspects, the causes, and how to deal with a stillbirth, how to break the news in front of the attendants. I think empathy is so much important whenever we are dealing with a case of stillbirth. I think empathy is very, very important, taking care of the patient as well as of her relatives, because I think it is a nightmarish experience for both the parents as well as the patient. So you have done it very well, Dr. Kavita. Best wishes for your future endeavors, and we all love you. Thank you so much.
Okay, thank you, madam. So I think most of them are busy, so couldn't join. So now we are moving to third session. For that talk will be given by Abharani madam. There is no introduction, but still is customary. So for that, chairpersons are Dr. Roma Yadav from our own society, Dr. Arpita Gandhi from Devghar. She belongs to Patna Society, and Dr. Bivaja madam, very senior from the Banga Society. So I request Biva madam to introduce Abharani Di. Viva madam, are you there? Have you joined? Viva madam? Anybody can introduce? Roma Di, are you there? Arpita Di?
I'm here.
Arpita?
Yeah.
Arpita is there.
Good evening and pranam to all. It's my proud privilege to introduce Dr. Abharani Sinha madam. First of all, I would like to pay my regards to all the stalwarts of the Foxy.
Roma Di, sorry to interrupt. We have less time.
Just I'm giving my salute to Dr. Abharani Sinha madam. She is the professor and HOD OBGYN KMCH Muzaffarpur, ICOG Governing Council member, President Patna OBGYN Society between 17 to 18, and she is the master trainer of Foxy MOC, and she has a special interest in high-risk pregnancy and vaginal surgery. Everybody knows Dr. Abharani Sinha, her talent, her smiling face. May I request madam to please start your deliberation.
Thank you so much, Dr. Roma, for your very kind introduction. I can see Dr. Arpita has also joined. So good evening to all my chairpersons, to all the stalwarts who have organized this program, Dr. Varsha Vaste, Dr. Pratibha Singh, Dr. Rekha Jha, and Dr. Kavita Barnwal. Hi to all of you. And now here I would like to share my screen. And I'm going to talk.
I will talk, Roma madam. I remembered you, how much you hate.
Yeah,
took me to the, and you fed me with your hands, delicious.
Thank you very much, ma'am.
Food
Thank
and
you.
fish and whatnot. I can remember it forever.
Waiting for your next visit also, ma'am.
Yeah, thank you.
Thank you. Pranam, ma'am.
Okay, so can everyone see my screen?
Yeah.
Yes, madam.
Yes.
Okay. So now, as this webinar is on identifying the risks, so now I'm going to another topic, that is inverted pyramid of antenatal care. Now, what are the objectives of antenatal care? The objectives are to screen the high-risk cases, to prevent or detect or treat at the earliest any complication, and to ensure continued medical surveillance.
The full screen kar lenge.
If we look at the pyramid of ANC, what we were doing in our previous days or in our early days was following the old model. That is
full screen.
more and more
Full screen kijiye Abhadi. Full screen.
It is full screen in my presentation.
Ma'am, can you please reshare it, ma'am?
Or should I reshare? Okay.
Priya, please help her.
Yes,
No, I'll stop share and again I'll share. No problem.
Okay. While sharing, please click on screen option, ma'am.
Yeah.
No, ma'am. It's not.
Okay. There's some problem.
Ma'am, while sharing the screen, there will be one screen window. You need to click on that and then share. Screen window.
Screen share screen to I'm doing, but screen window I can't find.
No issues.
Priya, if you can help her.
No issues, Abhadi. I think Abha ma'am, you can continue with that. It's not an issue. Abha ma'am का lecture ही सुनते हैं हम लोग, मतलब आधा time तो उसी में भी व्यस्त रहते हैं.
Lucius Abha madam, luminous Abha madam.
अब दिख रहा है.
Yes. Yes, दिख रहा है madam. आप करो.
Can you move to 3 slides, ma'am, and check?
I don't know why this is happening.
Abha madam, you continue.
Okay, good.
Enjoy.
Okay. So what we were doing in our early antenatal days were to follow the old model. That is, there were more antenatal checkups in the last trimester of the pregnancy, but now the pyramid is inverted. We are now following the new model, that is in which more and more emphasis is given in the first 12 weeks of pregnancy. Why? Because important complications that occur later in pregnancy can be predicted in the first trimester. Now, what are the advantages of inverted pyramid of ANC?
This helps in, ma'am, actually slide is not moving. Is it moving?
No. आबादी आप उसको resume slideshow में कर दीजिए.
Ma'am,
कोई
please
अपना mail
click on this
भेजोगे?
screen option, ma'am. Screen window, and then you can click on share so that slideshow will be visible, ma'am.
I am going straight to the share screen. I shouldn't go on that.
नहीं आप ठीक ही कर रहे हैं. आप ठीक ही कर रहे हैं. आप करिए.
Share
Ma'am,
screen
at
में
first
करेंगे?
share screen, ma'am, and then screen window, ma'am.
Screen window is where I can't see. Optimize for video clip.
On the
share
top,
sound.
ma'am, on the top left.
Okay, share.
Yes, ma'am. Perfect.
Yes, madam, now it's visible.
Perfect,
Okay.
perfect.
Thank you, ma'am. Thank you.
Thank you so much. Okay, so can you see the screen now?
Yes, madam.
Yes, madam. Yes, madam.
It is full screen?
Yes. Full screen, ma'am.
Yes, ma'am.
Okay. So I think I had already talked about, and now I'm going to talk about the advantages of having an inverted pyramid of ANC. It helps in early screening of fetal aneuploidies, early diagnosis of fetal abnormalities, and apart from that, it also helps in early screening for preeclampsia, fetal growth restriction, preterm delivery, and first trimester assessment of multiple gestation. Now, for aneuploidies, we all know that the first test that we do is the first trimester combined test, which the screening test components are the measurement of nuchal translucency, along with certain serum markers like PAP-A, free beta HCG or total HCG, and the blood is drawn at 11 to 13 plus 6 weeks, and NT is usually done between 10 to 13.6 weeks. And the detection rate at a false positive rate of 5% is as high as 85%. The advantage of this is the results are available in the first trimester, and it also helps to detect trisomy 18 and often trisomy 13. But the disadvantage is that it does not screen the neural tube defects. And the pattern that we find in Down syndrome is an increased HCG, decreased PAP-A, and an enlarged NT. So if we look at the effectiveness of the first trimester combined screen, it can be further augmented if we add other markers, other soft markers like nasal bone evaluation and Doppler evaluation of the ductus venosus and the blood flow across the tricuspid valve. It has been found that if NT measurement increased in fetuses with Down syndrome, it provides 51% detection of Down syndrome for a 5% FPR at 10 weeks, 59% at 11 weeks, and 62% at 12 to 13 weeks. So the best interpretation of NT is by screening programs that combine its measurement with maternal age and first trimester serum markers to provide a patient-specific list of Down syndrome. It is very important that whenever we are doing a first trimester screening for aneuploidies, we should always know how to interpret the report. Yes. Because we have to look on all the factors. We have to look at the NT, we have to look at the maternal age, and along with that, we have to look at the serum markers. And then we get a risk scoring. And according to that risk scoring, we know whether the patient is screened a low risk, high risk, or intermediate risk. Now, it is very important that whenever we are measuring the NT, the person should be certified by the SFM, that is Society of Fetal Medicine, because there may be variability in operator expertise and quality of equipment. So it has to be measured very, very accurately. So as I said, depending on the results, the patient can be a high risk, intermediate risk, or a low risk. If the patient comes as high risk, straight away we go for an invasive procedure. And if it is a low risk, that is 1 is to 1,000, we just reassure the patient. Whereas if it is an intermediate risk, then in this case, we can go for the stage 2 screening markers, where we use the additional USG markers. And if the final risk assessment in this group is 1 is to 100 or greater, we go for the invasive test. And if it is less than 1 is to 100, it is reassured. So what are the advantages of combined test? It is an early risk assessment. And along with that, we can also diagnose fetal abnormalities. And it also allows a good time for decision making. Suppose if the patient if they decide on termination, the termination is safer if it is carried out in the first trimester. The disadvantage is that we know that many of the Down syndrome babies, fetuses, then abort spontaneously. That is approximately 15% of Down syndrome pregnancy are spontaneously lost between 11 to 16 weeks of gestation, compared with less than 2% of euploid pregnancy. So it becomes then useless. Now there is another terminology as enhanced first trimester screening. So we can further increase the effectiveness of the first trimester screening by including additional maternal serum markers such as placental growth factor and maternal serum alpha fetoprotein. Now, quadruple test, suppose if we lose an opportunity to do a combined test in the first trimester, and if the patient comes late, then that is an opportunity where we can go for a quadruple test. There is now no value, or there is no justification in doing a triple test. What we have to do in the second trimester is a quadruple test, where blood is drawn between 15 to 18 plus 0.6 weeks, or it can be even done up to 22.6 weeks. Apart from the 3 markers, it also includes the inhibin A, and the detection rate is around 80% with a 5% false positive rate. The advantage is that it does not require ultrasound, and it can be offered to patients who present for prenatal care in the second trimester, and it also detects trisomy 18 and neural tube defects. Sometimes we may have to go for an integrated or sequential test where it includes the PAPE, the NT, and the HCG, AFP, unconjugated estriol, and inhibin A. Here, the first blood draw and NT are same as that for combined test, but the second blood draw is at the same time as the quadruple test. It has got a 94% for detection rate at a 5% false positive rate and 85% with a 2% false positive rate. It has highest detection rate for serum ultrasound test. It can also detect trisomy 18, often trisomy 13. And in the sequential format, usually the first trimester results are reported if very high, and the remaining patients, they go on to complete the second trimester part of the test, and then the test is revealed. There may be even a serum integrated test, which is same as integrated, but it does not consider NT. Here, the first blood is drawn in the same time as the combined test, and the second blood draw is at the same time as that for quadruple test. It has a screen positive rate of 85% with a 5% false positive rate. And it is especially for those patients who do not have a good access to an ultrasound, like in those patients who cannot do an NT scans, and the cell-free DNA, or we normally call it as NIPS or NIPT. These days, we better call it NIPS because it is a screening test. We have to understand it's not a diagnostic test. It is a screening test. And the components are genome-wide or targeted methods. The blood should be drawn. It is very important that the blood should be drawn at or after 10 weeks, because it is very important that what is the fetal fraction with us. The fetal fraction should be more than 4%, then only the results are variable. So it should not be done earlier. It should be always done after 10 weeks. The detection rate is very high, that is 99.2%, and it has got the highest sensitivity and specificity for all trisomies. It also detects sex chrome aneuploidies, and sometimes we may have no result. Then in those cases, we have to repeat the test. It is reasonable to use for secondary screening after prior serum screening positive before moving on to a diagnostic invasive test. So usually if we get a combined test positive, we may counsel the patient that you can go for a second screening test. And if that comes positive, then you can go for an invasive diagnostic test. Now coming to the early diagnosis of fetal abnormalities. These days with the first trimester ultrasound, we can have a detailed evaluation of the fetal anatomy, and about half of the congenital structural defect can now be diagnosed in the first trimester because of the improvements in the ultrasound technology. Even the nuchal translucency thickening and the presence of other ultrasound markers can herald the presence of structural defects. This is a long list that these are the anomalies which should be, these are the regions which should be examined, that is the head, face, neck, spine, thorax, abdomen, limbs, placenta, and cause. And accordingly, if these structures are studied, what are the structures we should see? I think they are very elaborately written. And what are the structural anomalies that can be recognizable as early as 11 to 13 weeks. Here we can see the different anomalies. Now, coming to the NT measurement, if the NT measurement is greater than 95th percentile, it can be associated with structural defects such as diaphragmatic hernia, omphalocele, facial clefts, body stalk anomaly, skeletal defects, congenital adrenal hyperplasia, fetal akinesia, Noonan syndrome, etc. And the risk of congenital heart disease increases progressively with increasing NT measurements. So NT is not always a marker for aneuploidy, but it may be associated with other fetal abnormalities. So a combination of 3 markers, NT more than 99 percentile, tricuspid regurgitation, and an abnormal A wave, it results in a detection rate of 52% for a false positive rate of 4.1%. Now coming to the screening for preeclampsia. Now this first trimester also gives us an opportunity to screen for preeclampsia, and it helps us to identify those women who are at risk of developing preeclampsia. And therefore, in these patients, we can initiate measures early to improve placentation and reduce the prevalence of disease. And if we know which patients are going to develop preeclampsia, we can tailor our prenatal surveillance to anticipate and recognize the onset of the clinical syndrome and manage it promptly. So even FIGO also recommends that all countries, all pregnant women should be screened for preterm PE during early pregnancy by the first trimester combined test with maternal risk factors and biomarkers as a one-step procedure. And there is a risk calculator which is available at the freemedicine.org, which helps to, in which you can fit your data and then you can get a risk scoring for preeclampsia. In combined test, we have the maternal risk factors, the mean arterial pressure, the placental growth factor, and the uterine artery pulsatility index. Risk factors, we all know that if any of the major risk factors present, like history of hypertension disease, chronic kidney disease, autoimmune disease, diabetes mellitus, chronic hypertension, or multiple gestation, or if there are two moderate risk factors, that is first pregnancy if the age is more than 40 years or less than 19 years, interpregnancy interval of more than 5 years, family history of preeclampsia, primary paternity, BMI at the first visit is very high, or in cases of IVF, these are the patients which may develop preeclampsia. And there have been various professional organizations which have identified these risk factors for identification of women at risk of PE, but it does not give a very good detection rate. In screening with the use of NICE guidelines, the detection rate is 39% for preterm preeclampsia and 34% for preterm preeclampsia at 10.3 false positive rate. So there is also a gestosis score, we all know, which is Gestosis Society is very popular in India, and they have developed a HDP gestosis score, which has got all the risk factors, and if the score is more than 3, then these pregnant women should be marked at risk of eclampsia. These are the different criteria which have score 1, 2, and 3, and these criteria, they help us to know according to the clinical condition that which women is more prone to develop preeclampsia. For first trimester screening, even mean arterial pressure is very important, and this has got a good detection rate for early onset. And if we combine it, definitely along with the other maternal risk factors, the sensitivity increases. The placental growth factor is also been seen to have a good prediction for preeclampsia as high as 55% with a 10% false positive rate. And it has been found that PLGF, that is placental growth factor, is superior to other biomarkers. And alone, it has got a detection rate of 56%. The other thing that usually in the first trimester, we are doing a PAPE. And if there are low levels of PAPE, then we are alarmed because that are associated with a higher incidence of preeclampsia. And there have been different studies, but all these studies, they have concluded that alone it is not an accurate predictor test for preeclampsia. Uterine artery Doppler, again, very important because we all know that one of the in the pathogenesis of preeclampsia, we have abnormal uteroplacental circulation, and this can be observed in the uterine arteries by ultrasound from as early as the first trimester of pregnancy. Here we use a transabdominal ultrasound, and the uterine arteries are identified, and with the color flow blood mapping, the uterine artery PI can be measured, and the average of the left and right uterine artery PI is used for risk assessment. The first trimester abnormal uterine PI is defined if it is greater than 90th percentile, and it has been found to have a detection rate of 48% at an 8% false positive rate for the identification of early onset preeclampsia. However, if we look for the late onset, the detection rate goes down. So risk assessment there's another model which is used for this risk assessment, which is known as base-based method, which combines the primary risk from the maternal characteristics and medical history with the results of various combinations of biophysical and biochemical measurement. So if a woman is high risk, then the risk is greater than or equal to 1:100, which is based on the first trimester combined test with maternal risk factors, MAP, PLGF, and uterine artery, PI. So here we can see it in a chart form, that is flow chart. That is, if we combine maternal characteristic, medical history, along with measurement of MAP with PLGF and UTPI, it all has to be done 11 to 13 weeks. If it is low risk, if it is less than 1:100, then the patient goes for a routine prenatal care. And if it is more than 100, then we give an intervention in the form of aspirin 150 milligram at night from 11 to 14 weeks until 36 weeks. In contingent screening, that is when the resources are limited, we cannot go with all biochemical tests. So in these cases, we just do a MAP along with the maternal risk factors. And if the patient falls in high group, then we go for the placental growth factor and uterine artery pulsatility index. Here we can see how to do a two-stage screening. First stage screening, only maternal factors and MAP. If it is a screen positive, then we go for a second stage screening. If it is screen negative, then we go for a routine antenatal care. And if the patient is screen positive, then we go for aspirin along with high dose of calcium and monitoring and surveillance for preeclampsia. So it has been found that if we go for a two-stage screening, it has got a good detection rate of around 71%. These are the different studies which have been done. And we find that the highest detection rate is when we are combining the risk, primary risk, along with the mean arterial pressure, uterine artery, pulsatility, PAPE, and PLGF. Now coming for small for growth babies, that is small for gestational age babies. In this, if there is an increase in uterine PI, then these are the cases which may develop fetal growth restriction later on. Decreased maternal serum PAPE, free beta HCG, PLGF, placental protein 13, disintegrin, and metalloproteinase 12, that is ADAM24. 12, they all have seen to increase the risk of SGA. It has got, with a false positive rate of 10%, these combination, they could identify approximately 75% of small for gestational age fetuses delivering before 37 weeks gestation and 45% that deliver at term. Apart from this, we can even screen for preterm labor if we go for serial measurements transvaginally of the cervical length, and this will help us to identify those women who are at risk of preterm gestation. Then even in multiple gestation, we all know that monochorionic twin pregnancies, they have got a higher risk of complications. So this, to determine the choriosity, an early week ultrasound can help us to know whether it is a dichorionic twin or a monochorionic twin. What we can see the typical twin peak sign in a dichorionic twin and a T sign in a monochorionic twin. So at the end, I would like to conclude saying that first trimester screening and diagnosis of fetal aneuploidies and anomalies help patients become aware of these conditions early in pregnancy, where they can make their decisions for termination of pregnancy. On comparing combined screening and cell-free DNA technology, both are efficient screening tests for aneuploidy early in pregnancy, but cell-free DNA is more accurate. However, combined first trimester screening casts a much wider net in terms of variety of fetal defects it can detect. Therefore, cell-free DNA technology should not be a replacement for traditional first trimester screening. Screening for gestational hypertensive disorders and small for gestational age fetus in the first trimester helps to choose women who are at an increased risk, and these women can be monitored more closely later in pregnancy, and prophylactic medications can be started early in pregnancy, which can lead to a significant reduction in the incidence. And in those pregnancies where multiple fetuses are identified, the first trimester represents an ideal time to determine the chorionicity. Thank you. Thank you so much for your patient hearing.
It's really nice and a wonderful presentation, madam. So now I invite Chairperson, Dr. Arpita Gandhi Di. Are you there, Arpita Di? Yes. She had joined. Yes, yeah. So you can give some, I think you must be PG student of Abhadi? So
No,
just
she
give
was
it
my
to-
colleague, not a PG student.
Okay, yes, better.
No, but when she was doing her PG under Dr. Santi Roy's unit, I was in Dr. N.K. Sahu's house surgery.
Okay. Okay, so just Arpita Di conclude, and Kumudni madam and Archana Di all have joined now. They had not joined last time, but now they are have joined. So just conclude, Arpita Di.
Abadi is well known to everyone, and Abadi is my umbrella. After the passage of Sahu sir, I thought I have become orphan, but now Abadi has.
Yeah.
We
Kumudni
cannot
madam.
hear you, Arpita. Try to be loud. I think. Hello.
Arpita Di has muted. Kumudni madam wants to give some comments.
Yeah,
आप दोनों सेशन का दे दीजिए इकट्ठे ही जल्दी में.
I'm scared. Kumudni will be asking some questions. I'm scared.
Oh no, I'm not asking any questions. You've covered everything. So you've left nothing unturned to be questioned about. And Kavita, and as Madam has said, Alka Pandey Madam, that Kavita, Rekha, and Pratibha, all of them are doing webinars so often that they'll update the whole Foxy Society with their webinars. And it was a really excellent talk. It was nice hearing you. And
thank you, Kumudni. Thank you.
Thank you, Kumudni want to say, Archana Di, we were not there. So now you can say a few words. Archana Jhadi, are you there? Okay. So I think Arpita Di want to say anything?
Just I want to say,
Abarani Sinha, it was excellent, very nice talk. Really loved it.
Thank you, Dr.
Luminous, Lucius talk. Luminous Abarani ka Lucius talk tha.
No. It's the
Bibha
love
madam.
of people
Okay,
from
Bibha
Bihar.
madam is there. Bibha ja madam. So you can say a few words.
Want to say something?
Bibha madam, she was chairperson in this session.
Is Vibhati there? I didn't see her.
Yeah, she has given comments. She has written in chat box. Bibha madam.
Okay.
I think many persons are not able
to
to
move for panel discussion because by 6:30 we have to close down. The link will be given to another webinar.
Dr. Vibha has joined with the delegate link, so she is not being seen here, and she's writing that I can only see, I cannot, I'm not seen there.
Kavita, just I want to conclude. This is a wonderful talk by Avarani madam. And previously we were thinking that the close observation during the last trimester of pregnancy is really meant for the patient and for us also. And we are taking the great care in the last trimester. But by hearing this talk, it is very much necessary to take care of our patients in the first trimester so that we can pick so many things, so many problems like the different type of congenital anomalies, preeclampsia, and a small for gestational age baby, all these things. So this inverted pyramid is a very wonderful thing for the safety of the patient, for the sake of the baby and the mother, and for us also. And we will have a great pleasure to have a very good baby at the real time. So, ma'am, thank you and congratulations for such a wonderful talk. I salute you, ma'am, and pradam to all.
Vibha has joined. I think she is now visible. So let's just hear from her for 1 minute. Vibha De?
Okay, let us go for the panel discussion. Pratibha and Rekha, please take over. Dr. Kavita.
Hello. Yeah. So now we will move on to our panel discussion. And we have moderators, Dr. Rekha Jha madam. So we all know she is the president of Bhagalpur Obs and Gynae Society, a very versatile personality. She is also the active member of IMA and Bhagalpur Menopause Society. She has been already introduced. So welcome, Dr. Rekha madam. And our next moderator is Dr. Kavita Barnwal. Again, a very dynamic personality of our Bhagalpur Society. She is the secretary of Bhagalpur Obs Gynae Society. So with this, I will also want to introduce our panelist. So our first panelist.
I will do that.
Okay, you do it. Yeah. First panelist is Dr. Rekha. Dr.
Varsha madam wants to do that.
Yeah. Start.
So thank you everybody for giving me the opportunity to host the webinar in Patna, Jharkhand, and Bihar, OBGYN Society. So let us see the esteemed panelist, Roma Yadav. She doesn't need introduction. Such a generous, kind-hearted, very nice person, Vice President of Bhagalpur OBGYN Society. We will just brief in 1 or 2 words because we have to finish up the panel. Then next is Dr. Sangeeta Thakur. She is a practicing consultant gynecologist in Isar Nursing Home and Secretary of Saharsa Obstetrics and OBGYN Society. Welcome, Madam Dr. Sangeeta ji. Dr. Lata Gupta, consultant of Lata Nursing Home and founder secretary of Sita Mari Obstetrics Gynaec Society and past president of Lion Club. Also, and she has many credentials. Next, Dr. Leena Nair, Lal. Consultant OBGYN, she has clinic in Bhagalpur and past secretary of Bhagalpur OBGYN Society, treasurer of Bhagalpur. Dr. Nivedita Datta, she is a consultant, president Bokaro OBGYN Society and East Zone coordinator of Self Motherhood Committee. Next, please. Dr. Archana Kumari, congratulations, Dr. Archana Kumari, for you are confirmed with the professorship, and she is associate professor, but now she is a professor at Ranchi Medical College, and she has many affiliations. Next, Dr. Ranjana Sinha. She is a chief consultant of Gynaec Clinic Patna and ex-head of OBGYN East Central Railway Patna, and definitely many credits to her, many credentials to her credit. Sipra Singh is a professor of Department of OBGYN, Katihar Medical College, Katihar, publications, many publications she has, and special interest in infertility. Next, Dr. Aarti Divya. Dr. Aarti Divya, you look so beautiful, and I'm really happy for you to be here. Thank you so much. So let us start the panel. Can you please
Dr. Aarti Divya is oncologist, madam. She's my batchmate. She's oncologist at Banaras.
Oh.
Yeah, she is
nice meeting you, Dr. Aarti Divya.
Thank you, madam. And thank you, Dr.
Thank you so much,
very
Dr.
active.
Aarti Divya, for being here. Thank you so much, because your presence is more important for such panel.
Can you see my
cervical cancer prevention? Next.
Yeah.
Can you see my panel?
Yes, we can see.
Yes.
It is full
Next,
screen.
please.
It is full screen?
I cannot.
No, not yet.
You will have to forward it. Pratibha or Kavita, who is doing it?
Yes, now
they've already been introduced.
The panel is on cervical cancer prevention.
I want to appeal again from my side. We must vote Dr. Varsha Vaste. She is the aspiring candidate for the vice president post. So all the best, Varsha Vaste, madam. And this panel has been prepared by her only, and it is her graciousness that she has given us to moderate this panel. So I will request Varsha madam to kindly start the panel and give some introduction to this.
Thank you. So cervical cancer, I will just brief in the beginning and you take over for the cases. Cervical cancer is the 4th most common cancer in women and the 7th overall. Large majority, around 85% of global burden, occurs in less developed regions like India and all developing countries, where it accounts for almost 12% of all female cancers. So why women are dying? Women are not dying because of disease we cannot treat. They are dying because societies have yet to make a decision that their lives are worth saving. Next. So the capacity to prevent cervical cancer requires more than a high-performance screening test and screening guidelines. It's a long-standing, slow-rising cancer. So definitely we can catch it at the right time, and we can prevent its occurrence also by good vaccination and awareness programs. So the architecture to eliminate cervical cancer is the threshold is all countries to reach less than 4 cases per lakh women is the threshold, and the target control is by 2030 is 90% of the girls should be fully vaccinated with HPV vaccine by 15 years of their age. 70% of these women should be screened with high precision tests by 35 and 45 years of age, and 95% of the women identified with cervical cancer disease should receive treatment and care. And the target is also 30% reduction in morbidity of NCDs. Mortality due to NCDs. The primary prevention is 90% of these girls should be vaccinated by the age of 15 years. Around 71.4 million girls were seen in India by 2020. So 90% is 64 million. And every year you have to add 1.14 million to this cohort. So we have to target that for prevention of cancer by HPV vaccine. So vaccine hesitancy is there. मुझे नहीं लेने का, costly है, sexual promiscuity, the side effects are there, cost effective. But overall, the vaccine is very, very important. We have to counsel the parents and the girls also why it is so important. So tell parents that almost everyone gets HPV. It can cause variety of cancer in women and men. Remind them that cancer prevention is applicable only with HPV vaccine, and provide strong recommendation for HPV vaccine. You have to tell each and every parent, girl, each patient, counsel them when they are 9 to 10 year old. When girls, they should be counseled and prepared for vaccination, and before 15 years of their age, they should be vaccinated. So listen carefully and welcome queries, especially about the safety of it.
Now this we have come to the
Over
first
to you.
case. Yeah. This is the case for Dr. Aarti Vidya. What is the role of VIA? I think this is a very, very simple case.
First of all, at the outset, I would like to give my
Apology.
sincere thanks to the organizers for giving me the opportunity to participate in such a wonderful webinar, especially this panel, which is very close to my heart. What is VIA? I think everybody must be knowing about VIA. It's a visual inspection of cervix with the help of acetic acid. What we do, we inspect the cervix by applying acetic acid, and it's a method of screening of cervical cancer to screen the cervix if there is any undue changes in the cervical cells, because the cervical cells, those who are going towards the abnormal size, the direction, they have the changes because of the high protein in their cells, and they get coagulated after the application of acetic acid. And this is the indication, and they look more opaque. And this is the indication that there are some changes in the cells of the cervix, and it is a useful method in low resource and middle income countries like India and all. And it is indicated for the female between the age group of 30 to 65 years of age. And it's only disadvantage is it's a very subjective finding, and we can over treatment can be predicted while using this method of screening.
The advantage is that we can immediately see and treat is the main advantage of this thing. Okay, thank you, doctor. Now this question is for Dr. Roma. Categories for VIA test result. What are the categories?
As what Dr. Aarti Vidya told, that this is due to the abnormal cellular protein which coagulates with the application of this 4% acetic acid, and there occurs the opaque white lesion that is called aceto-white lesion. When this aceto-white lesion is near the squamocolumnar junction, then it is significant. When it is away from the squamocolumnar junction, or far away, or not touching the squamocolumnar junction, then we are not taking it significant. And in this case, the further screening can be done, or the routine screening will be done. But if it is touching the squamocolumnar junction, the case should be taken up for further investigation, like co-testing, HPV, DNA testing, or colposcopy, or anything more.
So this is the recommendation by WHO suggesting using the following strategy for cervical cancer screening. For the general population, the main advantage is you can screen and treat. Screen, triage, and treat is mainly for those who have, along with the HIV infection if it is there. So HPV and DNA are the primary screening test, staging at the age of 30, and every 5 to 10 years screening interval should be there. And for women living with HIV, screening, triage, and treat should be the only treatment. And HPV and DNA are the primary screening test, and starting should be from 25 years. every 3 to 5 years, the screening interval should be there. So this is the pictorial depiction. Now, choice of screening, and these are the choice of screening and treating for the versus screen triage and treat strategy test. Impact of both strategies is similar. That is reduction of cervical cancer, and it reduces and decreases the both population of the women. And health system with triage, it causes reduction by half of the number of the precancerous treatment. The cost of HPV alone and HPV with triage are similar. Treatment with HPV alone, fewer treatments with triage, and greater cost of additional testing was with triage. Choice depends on the context, the capacity of the healthcare system to provide triage compared to without when not use triage, and the access to the service, and HIV prevalence, and the accessibility of treating women without lesions. So this is what it is there. Now, what is the ablative procedure available? I'll hand over the session from here to Dr. Rekha Jha, madam. So this is the question for Dr.
Nivedita. Dr. Nivedita, what are the ablative procedures available? Are you there, Dr. Nivedita?
Yeah, see there. Nivedita, are you there?
Dr. Nivedita,
take over the question, or if you're not there, then I would like to ask this to.
Hello. Yeah. Hello, Kavita.
Hello. Yes, yes. Dr. Aarti was.
Yeah.
Dr. Aarti, you are speaking.
Yeah. There are various
procedures.
Yeah, there are so many procedures. The most common one is the. I think
somebody
like this is there are various methods of ablation. The commonly used method is cryotherapy. And the second, the most, the recent one for India, not for the entire world, is the thermal ablation. It's very, easy to handle. The instrument is so handy that you can carry it anywhere in the remote areas to the outreach patients. And at a time, if it is charged, you can treat at least 40 patients in one time charge. And it is so handy that you can charge in the car also. So these are the two methods. Other than these two methods are the laser method. I have been using this, that is CO2 laser ablation, though it is not available easily to everywhere because it is very costly and it needs infrastructure to use it. And I think these are the methods that can be used for the, the ablative process.
Basic aim. What is the basic aim, Dr. Lata? Can you share?
Dr. Aarti, which method you will prefer the most? Like
thermal.
Thermal is the best, like the way we are using nowadays. This is best.
But one disadvantage is there is no tissue for biopsy. If there is any suspicion, then we can't get any tissue for biopsy.
For what? We have to do pap smear before, and first you have to diagnose it. Then
if it is CIN1 or like CIN1 or CIN2, we can go thermal ablation. But if there is any suspicion of high-grade lesion or invasive lesion, then we can't go thermal ablation only. We have to take the biopsy, whether with the loop or with any cone biopsy or anything else.
Yeah. Kavita, actually this thermal ablation or the cryotherapy is being used for the mass damping.
Yeah.
Where you are just you are just seeing and screening and doing treatment. The screen and treat method is applicable with this thermal ablation.
Thank you,
For cold application, cold cryo, you have to give it minimum for 3 minutes. The time is also very, very important.
And
most of the time, the liquid nitrogen, most of the time,
rapid freezing and slow thawing. That should be aim, na? Rapid freezing and slow thawing in case of cryocotton.
Madam, I am using cryotherapy for last 15 years, and in low resource setting, it is a very good method. And there is
even I like cryotherapy.
Yes, madam. It is 3 minutes freeze, 2 minutes thaw, and again 3 minutes freeze. And the results are very good. and very
Absolutely.
handy,
I'm
just a
also
natural
using.
center and a
I'm
crown
also
cleaner.
I think
Need of
Vandana,
anesthesia.
this thermal ablation, since I have got this thermal ablation, I'm very happy with this thermal ablation. It is very good.
Exactly.
I mean, it is
हमने thermal
very,
छोड़
very
दिया,
good.
अभी cryo में गए हम.
आप क्रायो को छोड़ के आप इस पे आ जाएंगे, हम लोग भी क्रायो
Thermal, thermal is actually more handy actually.
It's very handy.
More handy.
अभी मेरा थर्मल खराब हो गया ना तो क्रायो यूज हो रहा है अभी मेरा थर्मल खराब हो गया क्रायो यूज हो जाए
Anyway, okay, thank you. Now, next question is Dr. Archana. What are the advantages of excisional procedures? Dr. Archana Kumari.
Yeah, there are many actually local excisional procedure which can be used for CIN 2 and 3. Most commonly, we are using loop, that is, loop electrosurgical excision, loop electrosurgical excision, and also we can do lathes, that is large loop excision of the transformation. So the most obvious advantage, as it was being discussed previously, is the availability of the tissue for histopathology. And of course, LEAP can be done at outpatient basis. The instrument is less costly and requires less training. And the most important advantage is that the size and shape of the lesion to be removed can be adjusted by the shape of the, size of the LEAP and also by the direction of users.
Can be done in remote places also, Dr. Archana? Or you need to do in the OT only? I mean, if she starts bleeding or something, do you feel?
Yeah, actually, there should be some setting of OT, minor OT at least should be there to control the bleeding. Otherwise, it can be done in outpatient. It has to be, the advantage is that it can be used as an outpatient.
We should have that much control in our hand to decide that much only. Huh? Yeah, okay. Over to Rekha.
Ball cartridge use na, if there is bleeding, then we can apply ball for some time, and it usually controls bleeding. I also do loop.
Rekha, madam.
So she has. Should I go to the next question?
Yes.
So what is cold knife conization, Shipra? Shipra, Dr. Shipra.
Good evening, ma'am. Cold knife conization is the same as that we do cone biopsy. The entire cone of the cervix is removed. The scalpel is used as it is the same as a traditional method of performing the cone biopsy. So when there is any doubt about whether it is invasive or not, any doubt is there, we should remove the whole cone and send it for biopsy.
So what are the actual cases in which you want to do cone biopsy?
If there's a
when the lesion is extending inside,
when there's disparity between cytology, lesion extends inside, and there is suspicion of microinvasion, it's better to do a biopsy and then proceed for the treatment. But there are many side effects because it may lead to stenosis and infertility or cervical incompetence, depending. Bleeding may be there.
If the patient, she is quite of like 45 years age, completed a family, will it be different in that, and will it be different in the childbearing age?
If the patient now in our place there is belonging to low socioeconomic group, they can't come for follow-up very frequently. The follow-up is because the better they want to go for. In fact, we also prefer to go in total hysterectomy if required, because they won't come for follow-up.
So before that hysterectomy, would you prefer to do this conization?
Yeah, if there's a doubt, we can go for simple biopsy also. But if there is the lesion extend inside, you have a doubt. So no, it's better to go simple biopsy and then do
a hysterectomy in cases who are near about menopause and have completed family. And if the younger patients, you will do the cold knife surgical thing. Okay, thank you. So we can. Does anybody want to add something?
Yeah, I want to add something. Like if the lesion is see, when it is invasive cancer, there is no problem. You just take a punch biopsy. But when there is a doubt, the cervix is suspicious, and you need to diagnose whether it's a invasion or not, then we need to go for that. And the lesion, you are supposing it's a large lesion, involving the entire quadrant, then you need to go for the cone biopsy. And if suppose the patient, Yeah, and if suppose the patient hasn't completed her family and it's a micro-invasive carcinoma, then also we would like to go for the cone biopsy. And when we need the margins, because it gives you the, status of the margin also, whether the margins are positive or not. You may not find the status of the margin in cases of loop, but you get a very good status of the margin when you go for the cold knife biopsy. Yes, of course, it needs expertise to go for the cold knife biopsy.
Thank you, doctor. Over to Dr. Kavita.
Yeah, Leena Di, I think recently she has shared one thing about the vaccination. So just I want to know, is it possible to eliminate cervical cancer? It is being said that by 2029, there will be is a bit elimination like less than 4 cases per 1 lakh. So how and what are the factors which can contribute in elimination of cervical cancer?
I think it is very much possible to eliminate cervical cancer because as already told by Dr. Varsha Baste madam, she said that if we adopt the WHO's strategy of 90, 70 and 90, that is 90% of girls under the age of 15, they should be vaccinated, and we have a very effective vaccine. And now we're coming up with the Indian vaccine, which is also going to be available in the next few months. Then we should do at least 70% screening of our population in the age group of 35 to 45. If we are able to screen them and then adopt measures for management of these cases, if those females who are diagnosed with early lesions, we can go in for various ablative and excisional procedures and reduce the chances of them developing the full-blown cancer. And those who are already having cancer, if we are able to detect them at the earlier stages and adopt strategies for proper treatment and management of these cases and proper follow-up, it is very, very possible to eliminate cervical cancer. And WHO has adopted a resolution that if we adopt these procedures, then we'll be able to eliminate it by the year 2030. That is their strategy.
So very
Thank you.
said. Yeah.
Thank you. And
now
we all have to unite and we have to join in mass screening, mass vaccination, and then only we can achieve these targets.
And now
Thank
we
you so
are
much.
coming up with single dose vaccine also. Now
Yes.
we are coming up with the single dose
In younger girls, only 1 dose is says to be
now it has already
enough to
said,
provide immunity. Yeah.
Yes.
And I think Foxy should also take its initiative
Yeah,
to in the universal vaccination program.
Yes.
I
Foxy
think
has
they are
already
doing.
taken. Foxy
They
has
are
already taken
doing.
and
They are requested.
They have
government
requested the government to include it in
include
the
in mass
national
immunization.
immunization program. Yeah.
Yeah.
That vaccine is coming up by September.
Yeah.
Yes, yes.
I'll request Dr. Rekha Jha madam to take first case.
You have to move the slides. I don't have the slides. 33 years, para 3 patient, L1, discharged per vaginum for 1 year. The menstrual cycles are regular and the picture is shown. The cervix is unhealthy. Bimanual examination revealed a normal sized uterus. Bilaterally, furnaces were free and non-tender. After application of acetic acid, a dull aceto-white area was seen on the posterior lip of the cervix. To whom does it go? What is to be done? Dr. Lata Gupta.
See, as we know what is VIA, the visual inspection of the cervix on application of acetic acid. Suppose if it is dense, thick, opaque, and appears rapidly and is long lasting, definitely we have to worry. And I will go for colposcopy and colposcopy directed biopsy after taking the Swedish scoring.
So it was 7. The SWED score was 7. So in this case, you have to go. Does CIN1 progress or regress?
In some percentage of cases, CIN can regress, but 52% there can be changes seen with this. So we have to observe such patients. We are in patients where there is regression of the problem, we are not worried. But in some percentage, when about 32%, there can be some problems. So we have to observe such patients. But if they are unable or reluctant for the follow-up, then it is better to do some ablative treatment for in these patients.
Non-compliance of patient can be one of those, that if she is not going to return, then better do a procedure. And if she is under the surveillance, she will come back, then you can ask her to come back. What will be the period after which you ask her to return back for a re-examination for surveillance?
So every 6 months, we can observe her for cytology testing if we are suspecting CIN1 in such cases.
So the safety observation rather than the immediate treatment was illustrated in a randomized trial with low-grade cytology. So the trial found no significant difference in the rate of CIN1, 2, 3, and 8 at 18 months following immediate treatment with LEAP compared with the observation every 6 months. So both of these strategies can be followed. Either you can keep her under surveillance or you can treat her. So we can pass off to the next question, I think.
We have very late, 15 minutes only.
Yeah,
so we have to cover.
Okay. So this is the question for Dr. Sangeeta Thakur.
Hello,
What are
madam.
the situation where treatment is required for CIN1?
Usually, as we know, CIN1,
Madam, you are unmute yourself.
Yeah.
Sangeeta, you unmute yourself. Unmute karo, Sangeeta.
She is not muted, but it is, now she is muted.
Oh, sorry. Unmute karo, Sangeeta ji.
Sangeeta, unmute yourself.
And talk loudly.
Yeah. Okay. There is some network problem. There is some network problem. Nivedita, join. Nivedita, you want to take?
So no
Good evening, everyone. As has already been mentioned by Dr. Lata, that there would be some women who would not be amenable to follow up. So the conditions where treatment are required for CIN1 are: 1, where the women are definitely not going to be compliant for follow-up. Then 2, the one who are immunocompromised, especially with HIV positive. Then 3, where on follow-up after 6 months and again after follow-up after 1 year, we see the grading worsening or progression of the grading. And then finally, if the CIN does not disappear even after subsequent examinations and persists for 2 years. So these are the women where we need to have a treatment. And then secondly, is somebody who had a higher ASCAS earlier and then on later on follow-up has been found to be CIN1. So all these women are the ones which require treatment.
Thank you, Doctor.
And the patients who are requiring, and the patients, one more indication, and the patients who are requiring pregnancy.
Yes.
Yes.
Yes. Okay, now this question is for Dr. Ranjana Sinha. How you manage such patients after treatment?
Madam, since they are CIN1, so we definitely have to counsel them for careful follow-up, and we should screen them yearly. And we also have to look back at their HPV or cytology reports. And if the HPV test was positive or there was a low-grade lesions, then we have to screen them yearly. After 1 year, if the test is negative, then we can return to routine screening. But if it is positive, then we have to move to colposcopy and biopsy. And if there is CIN1, then we again have to repeat the cytology after 1 year. And if the test is positive, then we have to do colposcopy and biopsy. Now we have CIN1 persisting for 2 years, and that calls for excisional procedure. And if there was high-grade lesion, then either we have to call them at frequent follow-up with screening at 6 months, or we may directly go for excisional procedure.
Okay, thank you. Now this is for those who are desirous for pregnancy.
Pregnancy, yes.
Can elaborate it also? Yeah.
Yeah, in that case, if it is a low-grade lesion, again, we have to repeat cytology at 1 year. And if it is CIN1, then we will do colposcopy and biopsy and proceed further. But if it is a high-grade lesion, then we have to do cytology and colposcopy after 6 months. And if there is invasive disease, we'll refer her. And if it is non-invasive, then again, we'll repeat cytology and VIA colposcopy at 1 year. And again, if we find invasive disease, we'll refer her. If it is a high-grade lesion, then excisional procedure. And if it is a low-grade, then again, we'll keep her in follow-up.
So excellent, Dr. Ranjana. Now this is the case second. I'll request Dr. Kavita to take this case.
Yeah. So yeah, this case, this question goes to which the patient. Can you show the name?
Dr. Aarti.
Okay, Aarti. So this patient, 31-year-old, has come to you with persistent vaginal discharge and postcoital bleeding for last 6 months. She has one alive baby. Her cycles are regular, but on examination, perispectral examination, there was an irregular area that bleeds on touch. So it's most probably ectropion. And how are you are going to evaluate?
Yeah. See, you have already told me the perispectrum finding, but sometimes what happens is these patients, they may have some small polyp also, and that also bleeds on touch. And secondly, most probably they bleed because of the ectropion. And if she is having, associated infection, then I would like to go for the treatment of infection first, and then I would like to call her for either VIA or the pap test. And if it is needed, then I can go for the colposcopy, directed biopsy, and finally I would like to do, because such patients, they may feel good after certain ablative treatment like cryo or the thermal ablation. If it is proven biopsy, like there is no invasive lesion at all.
Okay, thank you, Aarti. And now what will be next step, Nivedita?
Dr. Aarti has already mentioned this. We have to treat her according to two things. One is to diagnose whether she has any pathology in the cervix, and two is to stop the bleeding, the postcoital bleeding which is occurring. So one was definitely, as I mentioned, that you do the screen by VIA or by the HPV and cytology, and then we do a colposcopy directed biopsy wherever we think that there is suspicion. And as per the, you've already given, I think the sweet score is 7 or 8 in this case. No? You've already mentioned that. So she definitely needs a colposcopy directed biopsy. And then you would also, as she has mentioned, Dr. Aarti has mentioned, to stop her postcoital bleeding, you would require some kind of a ablative procedure to symptomatically relieve her.
So she has been diagnosed as sweet score 8 and HPV CIN2. So Dr. Leena.
Yes.
Does she require any treatment in such case? She has this finding.
Since her score is quite high and it is diagnosed as CIN2, she does require some treatment. Hello?
Hello, yeah, tell
Yeah, you are audible.
Yeah.
She will be requiring treatment because she has already a very high score of sweet, and she has CIN2. So she will require some ablative or some excisional procedures, and then proper follow-up later on.
Anybody else can tell?
Aarti want to say?
See, CIN2 and CIN3, they are very difficult to separate from each other. Yes. And the situation is very dicey most of the times. So we should take care of the lesion, carefully. And since I think she was para-1, just ask the patient after doing the directed biopsy, if it is not an invasive cancer, ask her to complete the family. Okay, and keep her in close follow-up. And after completion of the family, we must advise her to go for the excisional biopsy, or you can say the therapeutic biopsy, you can say. And if the margins are negative, then again also we should keep the patient under close follow-up. And if suppose it changes into CIS or invasive or microinvasive, then we should advise according to her stage. So they need a close follow-up.
Yeah, there is one point now. This previous one. There is an alternative method of this triage study randomized that the creation of CIN2 is less likely in women with SPB 16 subtype. So if the SPB DNA has been done and if it is 16, then we have to be aggressive in treatment.
More
I think.
aggressive in treatment, yes.
Loop or cone, whatever is possible.
Excisional procedures.
Excisional.
Yes.
Archana has left because she had to deal some emergencies.
Dr. Aarti, you finished this full.
Ma'am, it's already been mentioned as a management.
But what is the role of markers? Is there any role of markers in this?
Though it is, there is role.
It is expensive, but there is a certain role of, it's very expensive. And if facilities are there, then one can definitely go in for the markers. For example, the NK cell markers, the 16 NK cell markers, and one can do that. That if the markers are positive, then there is a very high chance of progression. So then again, you will have to go in for the excision.
Okay.
True.
Markers also help us to evaluate our follow-up patients, how to manage them. If they those markers which are persistent, then we can go in for aggressive management. And if they do not have those markers and the HPV test is negative, then we can manage them in a less aggressive manner.
Generally, they are associated with high lesions and with type 16 and 18, mostly type 16.
16 and 18, yeah.
So they are of great importance for prognostic point of view.
Prognostic also, and then later on also, if you want to see whether, your marker, the levels are decreasing, then you can say that your treatment is, going in the right direction.
Yeah.
Also helps to evaluate that, the level of biomarkers.
Now this is for Dr. Roma. What already been said, but you said, you tell what.
The next thing in this scenario, in this very case, is to follow up. Follow up in 6 months, 1 year, and 2 years. The co-testing should be done. That is cytology and SPV DNA testing. And if it is negative, then routine screening. But if in this very case, this is CIN2 or 3 on histology, so colposcopy should be repeated and should be reviewed. If the colposcopy is adequate, there must be excision of transformation zone or ablation of the transformation zone. Then again, we are doing the repeat test of SPV and cytology at 1 to 2 years. VIA can also be done. And if the test is negative, again repeat after 3 years. And if again negative, the routine screening. But if it is positive, then we can do the excision or leap or ablation or anything. And if it is inadequate, EC positive and recurrent CIN, then diagnostic excision procedure can be done. If the margin is positive, repeat cytology and ECC at 6 months. And follow the management, follow the FOXI guideline. And if the margin is positive, repeat cone biopsy. And if not repeat cone biopsy, then hysterectomy, if can be done, if the cone biopsy is not practically feasible for the patient or the patient is non-compliant, then we can do hysterectomy.
Or if the age is more, then we can go in directly for hysterectomy.
In that case.
Yeah.
Now, what do you, Kavita, ask no? Ask.
Yeah, okay. So, Dr. Ranjana, do you think that
we will take only the last question now.
Okay,
Sorry for the interruption.
Okay, madam.
What is
So, this is last question. So, what are the situation for increased risk or recurrence or persistent? Dr. Ranjana.
Definitely, madam. We will have to follow up them carefully. And if the margins on excisional procedure, if the margins were positive or initially the lesions were large, or if their age is more than 40 years, or there is glandular involvement. Again, HIV co-infection is another condition where we have to keep them in follow-up more frequently. And like 6 months, 1 year, 2 years. And if they are negative after that, only then we have to return to routine screening. If at 2 years also they come positive, then again we have to follow the colposcopy biopsy and excisional thing.
Thank you.
Madam, can we hear one line from each panelist?
No, one more case
to prevent cervical cancer?
Hello, Kavita, one more case is there.
Madam Boli, there is no time.
No,
Is
this
there?
case she wants to
So
take.
we can take one case. What is ascus? We can turn.
Dr. Varsha madam, you only take this case.
Yeah.
You start.
Okay, a 31-year-old lady, para 2 comes with a pap smear report of ascus. So next. So what is ascus? Dr. Lata Gupta, can you highlight? Sometimes the sample is not adequate also. So what to do? What is ascus?
We know what is ascus. It is the atypical squamous cells of undetermined significance. These are the abnormal cells which we are seen in the pap smear testing, and they exhibit some abnormality. Either they have the enlarged nuclei or irregular in shape, and they cannot be definitely classified whether they are benign or precancerous. You can also mimic, some infective cells. They could like metaplasia cells. So ascus is, they are the abnormal squamous cells which usually we see in the pap smear testing.
So high grade is H. Ascus H. ACH. Okay, next. So with the ascus, the risk of cervical neoplasia, we can determine if the ascus CIN plus 2 is 6.9, CIN plus 3 2.6, CA, and cancer it is 0.18, HIV positive and HIV negative. So this everything will tell us about the progress of the disease and how to treat and what treatment one should give. So ascus is atypical squamous cell, undetermined. Colposcopy is a must when it is a high risk ascus HPV positive or HPV negative. Repeat pap smear after 4 to 6 months. Then HPV positive ascus, then reflex testing or co-testing with colposcopy should be done. Negative colposcopy result, then co-testing after 1 year. If the co-testing is HPV negative and cytology negative, return to age-appropriate testing for 3 years, after 3 years. And if all tests are negative, routine screening is done. So, okay, next. So, okay. Okay, I think we should conclude now because it's almost 6:30. So what do you organizers?
Yeah, so just I want to listen one line from all panelists. So how can we prevent cervical cancer? Just in one line. Everyone's view, we can take, everyone can share one line.
See, cervical cancer, in my view, cervical cancer, the biggest carcinogen is lack of awareness, lack of, ignorance and poverty. They are the biggest carcinogen. If we can make the public aware, starting from the very beginning, doesn't matter he or she is a boy or a girl, old or young, male or female, it should start from the very beginning in the family to see what is cervical cancer. It's not a disease, it's a preventable disease, it's a preventable happening, it's an infectious disease, and we must teach every child about the safe sex.
Vaccination. For joining and giving us good inputs. Very good.
Thank you.
Vaccination is my friend. Vaccination is the main aim. It should be the main aim for the prevention of this, for the elimination of this cervical cancer by the year 2030. So vaccination is must. Vaccination is always must, and every mother should be promoted, should make aware about vaccination.
Okay. Vaccination should be both for girls and even for the boys also.
Yeah.
Dr. Ranjana, making people aware about both the vaccination and regular pap smear or screening. Both of these things are important, and we must counsel them for the proper compliance from the age from 30 to 65. They must undergo routine pap screening also, and definitely vaccination, as government has already included in National Immunization Schedule. We hope for the best.
Dr. Nivedita?
Definitely prevention by not only vaccination.
I would like to tell Dr. Aarti Divya to go in the question answer and answer the
queries. Dr. Aarti.
Oh, just read out the question. I would like to answer.
It is in the chat box actually. Question.
Okay.
Management of 45-year patient.
Sipra, you want to say one line? Sipra, how to prevent cervical cancer?
You write down the answer, Aarti Divya.
You have to.
I would like to say that.
Hello.
Please
there should be awareness among the definitely increasing awareness among the general public is of prime importance, but also amongst the doctors, because a lot of doctors would not really encourage regular counseling and follow-up. So that is also extremely important, that everyone be on the same page. So what has been mentioned repeatedly, we should reiterate it. It should be there in our OPDs, and that cancer cervix is preventable, and what are the modalities of prevention, so that everybody who comes to our OPD can at least take one look at it.
Thank you. Thank you. Dr. Leena. Dr. Leena.
I would like to say that at the basic level, in the school level, we must give them good sex education and raising awareness regarding the effectiveness of the vaccine and the ease of screening, because it is an organ which is so accessible for screening. So that should the people should be made aware of these facts.
And very good. Very good. Dr. Shipra, you unmute yourself. Unmute yourself. I want to say that now we have self-examining kits are also available. PAPs
are available, yes.
So you can do it at your home comfort. So that is also we must promote.
Yes.
Absolutely.
Education, make the girls' education awareness at the school level, and make the girls aware of the vaccine as well as regular screening of their mothers and their.
Thank you.
Sangeeta Thakur.
Sangeeta Thakur, yes.
तुम इसको हटा दो, इसको हटा दो।
संगीता जी प्लीज, संगीता जी अपना इसको निकाल दीजिए, ईयरफोन्स निकाल दीजिए।
अब बोलो। इसका क्या है?
नहीं, ईयरफोन्स को लैपटॉप से भी डिस्कनेक्ट कीजिए।
लैपटॉप से निकालिए।
लैपटॉप से हटा दो उसको। लैपटॉप से उसको हटा दो।
ओके।
छोड़ो, कोई बात नहीं।
Anybody answer question in the chat box? Did anybody answer the question?
Dr. Aarti Divya, you have to answer this question.
Just listen to the question.
Madam, I'm unable to see the questions.
I am telling you the question. Wait. Management of the 45 patients found positive for 35 HPV. The strain is 35 HPV. Cytology is NILM. I don't know what she means by that. Patient had
LSI.
35 HPV 35. I don't think any genotype is available right now in India to test for the HPV 35. We just have the genotyping for type 16 and 18.
16 and 18.
So maybe she is positive for high risk HPV, and you just keep her in follow up. Simply keep her in follow up. 35 is not so
Dr. Manju Sharma, you got the answer. Thank you.
So now,
Okay, thank you.
Yeah, vote of thanks. So on the behalf of Bhagatpur Afghani Society, my heartfelt thanks to today's chief guest, Dr. Pai sir, Foxy President, guest of honor, Dr. Manjugita Mishra Madam, Dr. Anita Singh Madam, special guest, Dr. Alka Pandey Madam. Sincere thanks to all the speakers, Dr. Varsha Baste Madam, Dr. Kavita Bapat Madam, Nava Rani Madam, for their elaborate and brilliant presentation. My sincere thanks to all the chairpersons, Dr. Kumudni Jha Madam, Dr. Viva Jha Madam, Dr. Rekha Jha Madam, Dr. Archana Jadi, Dr. Arpita Gandhi Di, Dr. Roma Yadav, Dr. Supriya Jashwal for chairing and giving their expert comments. Lastly, I'm thankful to the most brilliant and moderator of this panel, Dr. Varsha Baste Madam, who had worked so much in preparing this PPT, and Dr. Pratibha Singh, who added some slides, and Dr. Rekha Jha Madam, who moderated the session in such a brilliant way. And lastly, I'm thankful to all the brilliant panelists, especially Dr. Aarti Divya, for giving her inputs, Professor Archana Kumari, Professor Sipra Singh, Dr. Roma Yadodi, Dr. Ranjana Sinha, Dr. Lata Gupta, Dr. Sangeeta Thakur, and Dr. Nivedita for joining this panel and giving the answers. And I think we Foxians, along with the government, will conquer and can eliminate the cervical cancer by 2030. Like Varsha Vaste Madam and all the chairpersons can lead this, and we can prevent this cancer, eliminate the cervical cancer. So
Madam,
thank you for giving me
one question I have. Last one question. How should we counsel patient who has HPV positive test, positive test? How should we counsel her?
HIV positive. They require more
HPV test.
Proper follow-up.
I mean,
we are going to follow up. But that time, how we are going to tell her?
That is something abnormal.
You have to follow up by vaccination.
Only one person should speak. Just choose from whom you are asking. Ask one person.
Dr. Aarti.
Yes, madam, boliye.
Answer for this.
If it is HPV positive.
See, I couldn't get the question whether she wants to counsel for, I mean, the HPV positive patient, how to follow up, or she wants to counsel her to go for HPV testing.
No. She is already HPV positive. The test has come HPV positive.
How to tell?
What should I tell her?
Have to wind up now because the target was 6:30 p.m.
Okay,
thank you so much.
Thank
They have to join with another.
Ma'am. Bye.
Thank you very much, madam.
Thank you so much,
Bye.
Rekha. Love you,
Thank you, Kavita. Thank you, Archana.
Thank you, madam. Thank you and all the best.
Thank you, ma'am.
Thank you and happy new year.
Time पे खत्म हो गया मैडम.
Thank you, Varsha ma'am.
Okay.
Thank you, Roma ji.
Thank you everyone.
Thank you, Nibedita,
All the
Suman,
best, ma'am.
Aarti ji, mast hai, Ranjana ji, and Lata Gupta, and Leena Nair. You were excellent. It was fantastic. Thank you so much.
ma'am.
Thank you. Bye bye.
Elections, ma'am.
Thank you for the opportunity, everyone. Thank you. Thank you, Kavita Di. Thank you, Pratibha Di. Thank you, Rekha ma'am. Thank you, Varsha ma'am.
for giving the platform and pharma support. And I think we have.
Yeah, thank you, still people.
All the best. Vishal, good luck.
Yeah.
Yes,
Thank
yes, we are
you.
wishing you
Thank you.
good
Bye
luck.
bye. Bye.
Wishing
Bye.
her
Bye-bye.
madam.
Bye.
Thank you, Nishan.
Okay.